والصلاة والسلام على رسول الله صلى الله عليه وسلم. Welcome you all in Saudi German Hospitals Group. So my pleasure and honor to have you in the 10th Rheumatology Symposium. Now we'll start with the welcome speech with Dr. Walid, our CMO, SGH Riyadh. Welcome, Dr. Walid.
Thank you. Allah يعطيك العافية. Assalamu alaikum wa rahmatullah for everyone. Welcome with us. It gives me a great pleasure to greet our respected speaker, guest, colleague, and attendees. A pleasant good afternoon and welcome to the 10th annual SGH Riyadh Rheumatology webinar with the theme of updates and management. This event will surely provide the participants up-to-date information covering the specialty of rheumatology. Our world is constantly changing. Therefore, all medical practitioners must always be attuned to the changing times in order for them to be at the bar with other medical practitioners in the world. A continuous professional medical education is needed and is a basic requirement in providing safe and quality care to the patients. It also provides better coordination with other medical specialty in giving the correct diagnosis and patient management that will surely result in superior medical outcome and patient satisfaction. At this point, let me take this opportunity to commend the organizing committee and all involved in the preparation and making this event a success. It's an honor for me to be here with all of you, and hopefully we continue to strive to improve our healthcare services through conducting medical activities like this. My great appreciation also goes to our speakers for the wholehearted sharing their time and knowledge in this event. Thank you very much, and I hope to see you again in future. Have a fruitful day ahead. Thank you, everyone.
Thank you so much, Dr. Walid. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين. الحمد لله إله الأولين والآخرين وقيوم السماوات والأراضين الذي لا فوز إلا في طاعته ولا عز إلا بالتذلل لعظمته ولا غنى إلا في الافتقار لرحمته ولا هدى إلا في الاستهداء بنوره ولا حياة إلا في رضاه ولا نعيم إلا في قربه ولا صلاح ولا فلاح إلا في الإخلاص له وتوحيد حبه الذي إذا أطيع شكر وإذا عصي تاب وغفر وإذا دعي أجاب وإذا عُمِل آثاب الذي لا تحلو الدنيا إلا بعافيته ولا تحلو الآخرة إلا بعفوه. فالحمد لله على ما أنعم به علينا من نعمه العظيمة، حيث أنزل إلينا أحسن كتبه وأرسل إلينا أفضل رسله وشرع لنا أكمل شرائع دينه وجعلنا من خير أمة أخرجت للناس. اللهم لك الحمد حمدا كثيرا طيبا مباركا فيه كما ينبغي لجلال وجهك وعظيم سلطانك عدد خلقك ورضا نفسك وزنة عرشك ومداد كلمتك. ثم الصلاة والسلام على سيد الأنبياء والمرسلين الصادق الأمين صلى الله عليه وآله وصحبه وسلم عبد الله ورسوله أرسله الله رحمة للعالمين وإماما للمتقين فشرح له صدره ورفع له ذكره ووضع عنه وزره وجعل الذلة والصغار على من خالف أمره. أشهد أنه قد بلغ الرسالة وأدى الأمانة وجاهد في الله حق جهاده حتى أتاه اليقين حتى أقام الله به الإسلام والملة إلى يوم الدين. أساتذتي وإخواني وأخواتي الأفاضل، أهلا بكم ومرحبا في المؤتمر العاشر للمستشفى السعودي الألماني لطب الأمراض والروماتيزم. Welcome you all to our 10th Saudi German Hospitals Rheumatology Symposium in its 10th edition. There is no field of medicine more broad and fascinating than rheumatology. Our field is, after all, the in vivo expression of immunology. Rheumatology, as well, is the sum of all symptoms, the accumulation of all physical findings, and the full expression of all laboratory abnormalities. It is really the library of all radiological manifestations and the catalog for all pathological features that can occur when the immune system is out of order, whatever the cause. Rheumatology is also the litany of local insults to joints, muscles, bones, and tendons that develop either acutely or as a result of wear, tear, overuse, aging, and other processes of life. Finally, rheumatology is the emotional impact of these disorders on the lives of human beings. There is no field of medicine in which the hands-on approach to the patient is more vital to making the correct diagnosis than in rheumatology. Finally, there is no field of medicine in which the therapists have advanced more dramatically since the start of this century than in rheumatology. Our growing ability to treat rheumatological problems and transform patients' life is a gift to the patients and a privilege for those who have loved this field, and we are proud of. Inshallah, we'll start our first session as usual with my dear professor, the very eminent and great Professor Dr. Adil. Dr. Adil is the Professor of Internal Medicine and Rheumatology. He is the head of Rheumatology Department at Shams University Hospitals in Cairo, Egypt. Dr. Adil is my dear supervisor for years. And we are proud of your sharing Dr. Adil every year at the start of our symposium. Dr. Adil, inshallah, this topic is about the assessment of ankylosing spondylitis. Please, Dr. Adil.
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بيك يا دكتور خالد، أهلا وسهلا بكل الإخوة والزملاء. ويلكم أول. أنا سعيد جدا بإني أكون مع حضراتكم النهاردة. إن شاء الله المرات الجاية نكون فيس تو فيس بإذن الله تعالى. أنا بس بسأل، أنتوا شايفين السلايد بتاعتي ولا لسه مش ظاهرة؟
Yes, clear, brother.
تمام. فمرة تانية أنا بشكر الأخ العزيز الأستاذ الدكتور خالد فتحي، وبشكر كل الإخوة الزملاء القائمين على هذا المؤتمر وإدارة مستشفى السعودي الألماني على دعوتهم الكريمة ليا. وأنا حقيقي ببقى سعيد جدا لما بشترك معاكم. إن شاء الله بإذن الله هكلم حضراتكم على الأسسمنت تولز إن أنكيلوزنج سبونديلايتس. My agenda, after a very short introduction, I am going to highlight the assessment of ankylosing spondylitis, including the value of the assessment, as well as the assessment tools, including a clinical assessment and laboratory assessment, before I conclude my presentation. Actually, I deleted the slides of radiographic assessment because of short of time. To start with, ankylosing spondylitis is an aggressive disease. It is a slowly progressive in most of cases, but it is an aggressive disease, especially if not properly managed and treated. It starts by inflammation, and this inflammation at the early stages of the disease leading to reversible disability, because this disability is due to enthesitis, due to asymmetric arthritis. But if the patient is not properly managed, definitely he will develop damage, and this damage will be followed by a new bone formation and definitely permanent disability, which impact the most basic daily life activity the patient wants to do. So early diagnosis and early management are very important for those patients having axial spondyloarthritis and ankylosing spondylitis. And for the proper management, there should be a proper assessment and the proper monitoring, because assessment and monitoring are the keys for optimizing the outcome of such disease. In front of you, the paper, which is published in 2017 by Joseph Smolin and his colleagues, addressing the treatment of axial SpA and peripheral SpA to target especially psoriatic arthritis, and they updated the recommendations. And these recommendations are 11 recommendations as well as 5 overarching principles. I am not going to highlight all the overarching principles as well as the recommendations, but I will highlight the overarching principle number B. Treatment to target by measuring disease activity and adjusting therapy accordingly, according to the assessment of the disease activity improves outcome. Hence, the assessment and the monitoring of the disease, different aspects of the disease are crucial to improve the outcome. Also, the recommendation number 6, which states that validated measures of musculoskeletal disease activity and assessment of cutaneous and other relevant extra-articular manifestations should be used in clinical practice. So the assessment tools I am going to highlight should be used in our daily practice in the hospitals, in the clinics, to assess the patient. What is the value of this assessment? To define the target and to guide the treatment decision. The frequency of the measurements depends on the level of disease activity. Hence, assessment and monitoring of disease activity and disease progression are very important to define the strategy of treatment and the different methods you are going to use with such patients. We have a lot of assessment tools. Assessment tools to address the disease activity, including the PASDI and SDAS. Also, we have to assess the function of the patient through the PASMI and PASFI. I am going to highlight all these measures. The assessment of response to your treatment, including the SS20, SS40, SS5/6, as well as SS partial remission score. To assess structural damage using either the conventional radiology or the X-ray or using the magnetic resonance image. Also, we have to assess the quality of life using the ankylosing spondylitis quality of life score. To assess the enthesitis, we have different tools to assess enthesitis. The most easy of these tools is the Leeds Enthesitis Index. And finally, lab assessment, including the ESR and CRB. Commonly, we use either the visual analog scale or the numerical rating scale to assess most of these measures. To start with the clinical assessment, if I have a patient with ankylosing spondylitis or axial spondyloarthritis, I have to assess the disease activity and the different disease measures clinically first. And this includes the test of tragus to wall distance. While the patient is standing, his heels as well as back pushing the wall, and you have to measure the distance between the tragus and the wall in both sides and take the medium of these two measures. Normally, it shouldn't exceed 15 centimeters. This tragus to wall distance measure or assess the thoracic vertebrae kyphosis. It is not assessing the cervical vertebrae. The modified Schuper test. Modified Schuper test is very important because it assesses the mobility of the entire lumbar spine. It includes measuring the distance between the level of posterior superior iliac spine, 10 centimeters above and 5 centimeters below, and ask the patient to bend his waist as if trying to touch his feet by his fingers and measure the distance, which is originally 15 centimeters. It should be increased at least 4 centimeters. Also, the lateral spinal mobility, you can measure the movement of the lateral spine by measuring the distance from the patient hand while he is standing in neutral from the patient hand to the ground, and then allow the patient to bend laterally and then measure again the distance. It should be exceeding 10 centimeters. Cervical rotation is measured by the goniometry, and there should be at least 70-degree rotation on both sides. Definitely, we take the medium of the two readings from the left and right side. The intermalleolar distance while the patient is lying on his back and straight lower limbs and abducting the hips maximally, and you measure the distance between the two medial malleoli and should be at least 1 meter. These 5 measures are called the PASMI. We are going to highlight it again within the presentation. Also, during the assessment, the chest expansion, while to measure the circumference of the patient chest at the level of the nipple, while the patient having a deep expiration and then deep inspiration, and the value should be increased during inspiration at least 2 to 5 centimeters. Hip rotation, because the hip joint is a root joint and commonly affected in patients with ankylosing spondylitis, and we have to measure by using the goniometry also the rotation, either internal or external rotation, which should be at least 45 degrees. These are important clinical assessment tools. Also, we have to make stress on the sacroiliac joints bilateral by applying pressure or percussion on the sacroiliac joints. The Faber test, from its name, F flexion, AB abduction, ER external rotation of the hip joint. So the patient, while lying down, we have to flex, abduct, and externally rotate the hip joint, applying a pressure over the knee to stress the sacroiliac joints. If there is sacroiliitis, it may be manifested by pain at the sacroiliac joint. Ganslin's test, like in the photo in front of you. Pointer option. Yes. The patient is lying down, and the non-tested side, there is a flexion of the hip and the knee and applying a pressure to push the leg of the lower limb on the patient chest. This is the examined side with the tested leg should be allowed to fall over the side of the examination bed and is pushed like this towards the floor. This is the Ganslin's test. It provokes pain at the sacroiliac joint. Examination of the upper limb, including the adduction and abduction, flexion, extension, also internal and external rotation and circumduction. You have to examine the patient's skin for evidence of psoriasis, because psoriasis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial SpA, inflammatory bowel disease, anterior uveitis, all these are including under the umbrella of spondyloarthritis. If the patient has an ocular complaint, we have to consult an ophthalmologist for the possible presence of uveitis, which is commonly in the SpA anterior uveitis. This is regarding the clinical assessment. Now we are going to assess the disease activity by the 2 measures. The first one is the PASDI, which is PAS is the name of the countryside where the rheumatologist grouped at that area to make these measures. So it's a PAS, ankylosing spondylitis disease activity index. The PASDI depend on a questionnaire of 6 questions. The first one addressing the fatigue and tiredness. The second one, the pain, whether in the back, in the neck, or in the hip. The third one is the peripheral joint pain and swelling. The fourth one is the level of discomfort when pressure on special areas, I mean enthesitis. The fifth and sixth questions about the morning stiffness, one about the level or the degree of morning stiffness, and the last one is the duration of morning stiffness. So we have 6 questions. This is called the BASTAI, and it is validated in Arabic like this. These are the questions for Arabic patients who can read, and if the patient cannot read, someone can help him and tell him what each question. The patient will mark at the level of which correlate with his condition. 0 means he is normal, there is no complaint, while 10 is severe condition. This is validated in Arabic, the BASTAI. These are the 6 questions, and this is the numerical rating scale, where 0 is normal or there is nothing at all, there is no problem at all, while 10 means very severe. If I'm asking about fatigue, no fatigue is 0, severe fatigue is 10, intermediate fatigue is 5. So the patient will give him the score. We calculate or take the sum of the first 4 questions the patient answered, and then we get the sum of the question number 5 and 6 about the morning stiffness. We again add the sum of the first 4 questions to the medium of the question 5 and 6. This is in the last 48 to 1 week. To give an example about BASTAI, this is the BASTAI, and we asked the patient the question. The first question, the patient gave the score of 5. The question about the back pain and neck pain or hip pain gives the score of 7. Score of 1 about the swollen peripheral or pain in the peripheral joints. Discomfort or enthesitis give 2. If you calculate 5, 7, it's 12, 13, and then 15. So the sum of the first 4 questions is 15. We come now to the 5th and 6th question. He gave 5 in the morning stiffness severity and morning stiffness duration. So the sum of these 5th and 6th question is 5. If you collected both or added both, so the total score is 20. It should be divided by 5 and 1, 2, 3, 4, and these are the sum of considered as a 1 question. So we divide by 5. If divided by 5, so the BASTAI is 4. When I tell the patient that there is an improvement in the BASTAI, improvement means decrease the BASTAI either 2 solid numbers, or it was 4, now it become 2 or 1.8, or decrease 50% relative improvement from the previous BASTAI. Nowadays, there is an important measure for the disease activity, which is the ASDAS, is replacing the BASTAI. ASDAS means ankylosing spondylitis disease activity score. The ASDAS is only 5 points. 3 points are repeated from the BASTAI, including the back pain, including morning stiffness duration, including peripheral joint pain and swelling, but we replaced the other 3 measures in BASTAI by just 2: patient global assessment of disease activity, as well as C-reactive protein or ESR. So ASDAS has a lab findings, but in the BASTAI there is no lab at all. When the patient score is less than 1.3, this is mean an active disease. Low disease activity from 1.3 to 2.1, high disease activity from 2.1 to 3.5, and if more than 3.5, this is a very high disease activity. When I tell to my patients that this is an improvement, we have 2 types of improvement. Clinically important improvement if the ASDAS decrease in 1.1 or more, and major improvement if the ASDAS improved at least 2. What about worsening? When I tell the patient that the condition is more worse than the previous visit, actually the assess defined the worsening to be 0.9. It means that if the ASDAS increased 0.9 or more, this is means that the patient is more worse, and you have to adjust and revise your strategy and your medications. As this actually is a mobile application, and I tried by myself this application. You can download on your smartphone. You can download the Assess application. It includes the ASDAS. The first, when you use this application, the first question is about back pain. I give myself 5 from 10. The second question about peripheral pain and swelling in the joints, I give myself 5. I tried for myself. Duration of morning stiffness, I give a score of 8. The patient global, again, I give 5 from 10. And the CRB, I selected CRB, not ESR, and selected CRB in milligram per liter and give to myself 2. And then I pressed on this sign of equal. He gave me this screen. It called my ASDAS is 2.6, and this falls in the high disease activity level. So it's very easy to apply the ASDAS, and the ASDAS is more accurate and give the truth about the disease activity than the PASDI actually. Now I am going to shift to another measure, which is a PAS-5, which measures the function using the numerical rating scale. It includes 10 questions, and the patient in each question gives the score which fits his condition. These are questions about the daily life activity, like putting on the socks, like the second question, getting something from the ground without help of others. Also give to take or to reach something in a high shelf without help. The fourth is to stand from an armless chair without help. Getting from the lying down on the floor without help to get up. These are 5 questions. The other 5 questions, standing unsupported for at least 10 minutes, climbing the stairs from 12 to 15 steps, also without using the handrail or walking aid and without support. Looking on the shoulder without turning your body, then the daily sports or exercise, and the daily activities, whether at home or at work. So these are 10 questions. The patient give himself the score of from 0 to 10, where 0 is very easy, 10 is impossible. And then we take the sum of the 10 readings to calculate the patient PAS-5. Also, it is validated in Arabic, and these are the questions in Arabic. You see, this is the rest of the questions that can be used in assessment of the patient function. Now I am going to the, again, metrology index or PAS-9, and we discussed this before, including the tragus to wall distance, modified Schuper test, lumbar side flexion, cervical rotation, intermalleolar distance. How it can be calculated according to the patient readings, we give a score. If all the readings are normal, so the patient will be scored 0. If there is a moderate affection, the patient will take a score of 1. And if severe affection, the patient will take a score of 10. So the total score is from 0 to 10, because if the patient has all the parameters, or the 5 parameters bad, so or worse, he will take a total score of 10. So the increasing score, it means a more worse the condition. It's the normal score from 0 to 10, and the higher score means a worse condition. This is regarding the PAS-5. What about Assess 20? SS20, actually, we use it in the studies, in the reading paper. You have to know what is SS20. It means improvement of 20% as well as 10 units in at least 3 domains. Patient global assessment by VIVAS, pain by VIVAS, function by BAS-5, which just we mentioned, inflammation by the medium of the morning stiffness severity and the duration. There should be improvement in at least 20% in at least 3 of these 4 domains without worsening in the remaining domain. 20% improvement and 10 units. SS40 is the same, but the improvement is 40% as well as 20 units in at least 3 domains without worsening of the 4th domain. This is the SS20, SS40. What about the SS partial remission? SS partial remission means improvement of a value of 20 in the all 4 domains: patient global assessment in pain, function, and inflammation, whether patient global assessment and pain are assessed in using the VAS, function by the BAS-5, inflammation, as we said before, the medium of the morning stiffness severity and duration. This is SS partial remission. What about SS 5/6 improvement criteria? Also improvement of a 20%, at least 20% of 5 from these 6 domains: patient global assessment, pain, function, inflammation as previous, as well as C-reactive protein and the spinal mobility test, while the patient flexes his spine to the right and to the left, and we said before that it should exceed 10 centimeters. These are the response to treatment by SS20, SS40, SS partial remission, SS 5/6. What about the assessment of enthesitis? There may be a question in the for some of colleagues that enthesitis it's common in psoriatic arthritis, not an ankylosing spondylitis. But I want to correct this knowledge. Enthesitis is the primary pathology in all spondyloarthropathies, whether ankylosing spondylitis, non-radiographic axial SpA, psoriasis, psoriatic arthritis, psoriatic arthritis, reactive arthritis. So enthesitis is considered the primary pathology in this group of diseases. We have a lot of assessment tools for enthesitis, including the SPARC, assessing 16 points. Also, we have the MACES score, but 13 sites, and the Leeds enthesitis index, which just 6 points. In each of these scores, I am pressing on the site prescribed of the score and give the score of 0 if there is no tenderness, or 1 if there is a tenderness. I think it is the most easy is the Leeds enthesitis index. Leeds enthesitis index, we have only 6 points to press: bilateral Achilles tendon insertion on both sides, medial femoral condyles, as well as lateral humeral condyles. So the score is from 0 to 6. This is the Leeds enthesitis index, which is published in 2008. Lastly, laboratory assessment. We haven't a lot of laboratory assessment, but ESR and CRB, all of you know that they are done specific, and there is a lot of causes which may increase both ESR and CRB. But I want to emphasize that CRB is included, number 1, in the classification criteria, SS classification criteria. It is one of the 11 SPA features. Also, it's included, as we just mentioned, in the SDAS. I told you the SDAS is 5 domains. One of these 5 domains is the ESR or CRB. The SDAS started to replace totally the BAS-5 nowadays. Elevated CRB and ESR is present only in 40 to 50% of patients with ankylosing spondylitis. It's important to know that normal ESR and CRB doesn't exclude an active disease. It may be of value in follow-up of patients with ankylosing spondylitis. Dear colleagues and friends, I omitted the slides of radiographic assessment because of short of time, but hoping with AS early diagnosis and the proper assessment as well as effective management to stop disease progression and to prevent the patient deterioration. Now it is the time to conclude my presentation, dear colleagues and friends. Actually, ankylosing spondylitis is a progressive disease if not treated. Assessment and the proper monitoring of ankylosing spondylitis are the keys for optimizing the outcome of such disease, hoping with ankylosing spondylitis early diagnosis, proper assessment, as well as effective management to stop disease progression. Finally, thank you all very much for your attention, and I hope a great success for such Congress. Thank you, dear colleague, dear friend, Dr. Khalid Fathi. شكرا جزيلا.
Thank you so much, Professor Dr. Ali Mahmoud. Nice presentation as usual. Inshallah, la quwwata illa billah. You stressed upon a very nice topic, practical one. Really, we cannot improve what we cannot measure.
Yes.
I know you have
دايما بنقول ان الانسان لم يتقدم يا دكتور خالد الا لما بدأ يقيس الوقت، يقيس المسافة، يقيس كل حاجة. هو ده اللي بيؤدي الى التطور الى الافضل باذن الله.
That's true. I know you have limited frame of time, but I have only one question about your daily clinical practice. Which score do you prefer and recommend?
Actually, I'm scoring the disease activity using the ASDAS. ASDAS is very easy. It is a 5 domains. It is an application on your mobile, so it's very easy to be applied. The only problem is the lab, ESR or CRP, because actually you know that we have a different labs with a different methods of assessment, especially in the CRP. This is only the problem, but I prefer the ASDAS. Regarding the clinical assessment, I am doing the clinical assessment at least two times per year, except if the patient has a recent complaint. So at that time, I have to repeat the clinical assessment, including the modified Schuper test or spinal flexion or tragus to wall, chest expansion, and these measures I said before.
Nice. Thank you so much, Professor Adel. It's really our honor to join with us every time. Alhamdulillah.
متشكر جدا دكتور خالد، شرف ليا. ومرة تانية بشكر إدارة مستشفى السعودي الألماني في الرياض، وإن شاء الله بإذن الله نلتقي دائما على خير. بشكر كل الزملاء والإخوة الأعزاء اللي معانا واللي سمعونا، وإن شاء الله نلتقي قريبا على كل خير. شكرا جزيلا دكتور خالد.
Thank you so much.
السلام عليكم.
We'll shift now to the second presentation on our first session. As you know all, we have the Saudi German Hospitals Group. We have a collaboration with Mayo Clinic since about 3 years in the scientific and the clinical lines. It's our honor and pleasure to share a very eminent figure in such specialty, Dr. Florine Ernest. She is a consultant rheumatologist. She is the director of rheumatology fellowship program in Mayo Clinic College of Medicine. Welcome, Dr. Florine.
Thank you very much. Today, I will be speaking about myositis updates in 2022. My disclosures are as follows. The objectives are threefold to this talk. I will be discussing the 2017 ACR-EULAR classification system for myositis. I will also have 3 myositis cases to discuss. In particular, the first will be the anti-synthetase syndrome, and then necrotizing autoimmune myopathy. And finally, I will touch upon 2 newer treatments on the horizon for dermatomyositis. This is the historical view of the idiopathic inflammatory myopathies. You can see the major subgroups are as follows: juvenile myositis, dermatomyositis, polymyositis, and inclusion body myositis. This historical view has since changed. Historically, it has been based on the 1975 Bohan and Peter criteria for polymyositis and dermatomyositis. And you can see in the criteria that there are 5 signs and symptoms that need to be addressed. And these include muscle weakness, muscle biopsy evidence of inflammation, elevated serum levels of skeletal muscle enzymes, myopathic changes on the EMG, and characteristic skin rashes of dermatomyositis. For a definite diagnosis of polymyositis, what is required is muscle biopsy evidence of inflammation. For a definite diagnosis of dermatomyositis, you can simply use the characteristic skin rashes with one of the 3 other criterion. Concerns with this classification criteria is that it is too simplistic. There have now been in development more tests that make the specificity of the diagnosis enhanced. So there are immunohistochemical tests available, and the Bohan and Peter criteria does differentiate dermatomyositis from polymyositis, but it does include or exclude the inclusion body myositis. It can also poorly discriminate from other neuromuscular diseases. And we know that there are myositis-specific antibodies that better define certain subgroups. Hence, this is the newer view of the idiopathic inflammatory myopathies. You can see that they are a complex and heterogeneous group of diseases. I will focus on these 3: dermatomyositis, necrotizing autoimmune myopathy, and the anti-synthetase syndrome. Dr. Ingrid Lundberg and her colleagues at the Karolinska Institute and internationally as well have come up with this classification criteria that has since been published in 2017. This classification criteria is for both adult and juvenile patients who have myositis. They group patients into definite, probable, or possible. The candidate variables were assembled from previously published criteria, with ultimately the original 16 variables being picked out of patients studied. There were 976 with the myositis, 74% adults, 26% children, and the patients who did not have myositis were 64. These were from 47 centers around the world. 2 models were developed with and without muscle biopsies. These models are, as you see here. In this table, you can see the variables on the left. They include age, clinical muscle variables, skin variables such as heliotrope rash, Gottron's papules, Gottron's sign, other clinical variables such as dysphagia, laboratory variables, and then the autoantibody positivity such as JO1 and muscle biopsy variables. So each item is assigned a weighted score without muscle biopsy data on this column and with muscle biopsy data in this column. They use probability cutoff percentages of 55% to correspond to a score of 5.5 or 6.7 with biopsy to mean probable in idiopathic inflammatory myopathy. Between these numbers would be possible, and then greater than 7.5 corresponds to definite. Overall sensitivity of 93% and specificity of 88%. So here is a case. This is a patient of mine. If you want to follow along, if you have a smartphone or laptop, you can simply plug in this website, and there is a web calculator present. This is at the Karolinska Institute in Sweden. This was a patient who presented with photosensitive pruritic rashes for 6 months. She reported difficulty with climbing stairs, lifting heavy objects. She denied dysphagia. Her exam was notable for violaceous rashes present on her face, posterior scalp, arms. She had periorbital edema, heliotrope rash, Shaw sign, Gottran's papules and sign. She had periungual telangiectasias with cuticle hypertrophy, evidence of muscle strength deficits in her upper and lower extremities. She did not have axial muscle weakness. Her labs were notable actually for a positive ANA, and that is it. The CK was normal. The rest of her skeletal muscle enzymes were normal. She declined an EMG or a muscle biopsy. So what is the probability that she could have a definite idiopathic inflammatory myopathy? Let's try this. So on her pictures here, you can see to the left, she has patchy violaceous rash of the forehead, the cheeks. On the lateral view, you can see signs here that would indicate the Shaw sign. Her arm to the left shows a streaking violaceous rash. You can see on her hand, Gottran's papules, here Gottran's sign, and then this is evident as part of having the Shaw sign. And again, more of the Gottran's papules. So she had a severe cutaneous presentation. Using the web calculator, as you can see on the left, you can plug in her age greater than 40. She had weakness. She had these rashes and signs. And if you click submit, her score is 14.2. So the probability that she does have a definite idiopathic inflammatory myopathy, such as dermatomyositis, is 100%. And that is what she has. So with treatment, her rashes resolved. More myositis cases I have to discuss. Case 2. This was a 35-year-old female. She had a previous history of Raynaud's phenomenon. She developed a dry cough and dyspnea on minimal exertion during the 3rd trimester of her pregnancy. She delivered her child, but then became hypoxic in the peripartum afterwards, and she was ruled out for pulmonary embolus, but her CT did show that she had ground glass opacities and infiltrates at the bases. Her CK was only mildly elevated. She actually did not have much weakness on her exam, but she did have a strongly positive JOB1 antibody, and her skin exam showed what we call mechanic's hands. That means she had dryness of the lateral borders of the index fingers bilaterally. She was admitted to the ICU, and this is when I saw her. She was not intubated, but she was on BiPAP. She required lots of high-dose glucocorticoids delivered intravenously as she was progressively getting worse and was in respiratory distress. We had to treat her with plasma exchange. She was started on rituximab and mycophenolate mofetil. The coronal view of her CT scan on the left reveals that she had low lung volumes. She had evidence of interstitial ground glass opacities, preferentially in the bases, but also extending into the middle and upper lungs. After treatment, when I saw her 1 year later, this is the coronal view of her CT scan showing near resolution of her interstitial lung disease. So what is antisynthetase syndrome? Please bear in mind, actually, there are there's a research project that is ongoing in terms of developing newer classification criteria. This is based on the Solomon criteria from 2011. What is required to have the antisynthetase syndrome is the presence of a tRNA antibody. This is a tRNA synthetase antibody plus 2 major criteria, or 1 major and 2 minor. The major criteria is defined as myositis by the Bohan and Peter, criteria and presence of interstitial lung disease. The minor criteria involves arthritis or Raynaud's or mechanics hands or a combination, and sometimes fevers can be part of the minor criteria. Many of the patients actually only have interstitial lung disease as a predominant feature of antisynthetase syndrome, with a minority of them experiencing also symptoms of arthritis or myositis. I see patients with antisynthetase syndrome in my practice, and the majority of these patients have the interstitial lung disease and minimal, if any, myositis. So this is a typical chest radiograph of low lung volumes, and you can see here fibrosis with honeycombing at the bases extending in the mid to upper lung zones. There are subtypes described with the antisynthetase syndrome, the most common being non-specific interstitial pneumonia, and then organizing pneumonia being most common. Less common, usual interstitial pneumonia. Diffuse alveolar damage is uncommon, as well as lymphocytic interstitial pneumonia. I have seen the coexistence of more than one subtype in a few patients. What about the role of autoantibodies? In the table to the right, you can see that the Jo-1 antibody is actually the most common to see, followed by the PL12 and the PL7. The less common are the EJ, OJ, and other antibodies. Less than 1% of the time, you'll see that anti-Ha or ZO antibody. They usually are mutually exclusive. If you see more than one present, this may be a lab error. These Jo-1 patients are the most common and were the first to be described. It is thought that perhaps the antibody may be pathogenic and activate the immune system, causing downstream inflammatory effects on tissues. This is speculative and not proven. The mechanics hands is actually part of having the typical characteristic of the antisynthetase syndrome, myositis, and the inflammatory arthritis actually looks like initially rheumatoid arthritis. In fact, I've seen patients who can initially be diagnosed with rheumatoid arthritis, and later it becomes known that they have the antisynthetase syndrome. Studies have shown that patients with the Jo-1 antibody seem to have a better survival than patients with the other antisynthetase antibodies, such as PL7 or PL12. There's also a myositis-associated antibody called the SSA antibody. This one is the TRIM21 protein that can coexist with a tRNA synthetase antibody, usually Jo-1. 50% of Jo-1 patients have the antibody, and if you see that this antibody with Jo-1, it seems to predict a more aggressive interstitial lung disease course, in addition to having joint and muscle disease. Why is that? We are not quite sure why is that, but these patients are less likely to respond to standard immunosuppressive therapy. There is expert opinion in terms of the approach to treating myositis-associated ILD. On the left are the patients who have the mild to moderate disease, and these are the patients you most often would see in the outpatient setting. In the inpatient setting, the patients on the right would present with rapidly progressive interstitial lung disease, such as the second case of my patient. What do I do for these patients? I initially will recommend mycophenolate mofetil, potentially can titrate up to a 3-gram dose. Azathioprine is an alternative. You want to assess their lungs serially every 3 to 6 months by PFTs and routine CT scans. If these patients progress, there's option to add on rituximab or tacrolimus. More and more antifibrotic agents such as nintedanib have now been used by lung experts as an adjunct therapy if there's progressive lung disease. What are the outcomes of these patients? The 5-year survival rate historically has been low at 60%. Thankfully, over the last decade, the survival rate has improved, going up to as high as 86.5% in some series. Relapses are common, but only if they're treated with single agents, such as glucocorticoids, or if their immunosuppressants are tapered or discontinued. What about case 3? We are switching gears to a different kind of myositis here. This is a 54-year-old male, works as a mechanic. He has a history of coronary artery disease. Several years ago, had stent placement after he suffered from a myocardial infarction and STEMI. He also has impaired fasting glucose. He reported difficulty with getting into his vehicle in the mornings. He had trouble with squatting and lifting his arms overhead at his job. He had myalgias primarily affecting his thighs. His history is notable for being on atorvastatin on a dose of 80 milligrams daily for several years. He actually discontinued it on his own due to myalgias. He went to his local physician. As you can see here, his CK was very elevated, greater than 20,000, normal being less than 200. His AST was elevated as well as the ALT. His family history was notable for statin-induced myalgias in a brother. He ended up having a positive antibody for the HMG-CoA reductase that was elevated at greater than 200. His EMG showed myopathy, and a muscle biopsy of the left triceps revealed numerous necrotic fibers invaded by macrophages. He had regenerating fibers and no inflammation. His diagnosis was necrotizing autoimmune myopathy, HMG-CoA reductase positive. He had risk factors, including in his brother having the statin-induced myalgias. We know by gene studies that the class 2 HLA allele, DRB1101, does increase the risk by these odds ratios, 25 in whites, 56.5 in African Americans. There are also SNP variants such as the SLC01B1, encodes a certain organic anion transporter that does regulate the uptake of statins in the liver. To have that polymorphism does increase the risk of having a statin-induced myopathy, which this patient has. What are other risk factors? We know that statin exposure can be the greatest risk factor. Indeed, case control studies have shown patients being on atorvastatin have that higher risk compared to other statins, although this may represent U.S. national prescribing practices as atorvastatin is most commonly prescribed, yet other statins have been implicated, as you can see. The presence of having type 2 diabetes also elevates the risk, odds ratio being high at 15.6, and then finally age elevates that risk. So what is the role of that HMG-CoA reductase antibody? It is a target of statins, this enzyme. It's a rate-limiting enzyme in the cholesterol biosynthesis. It was first recognized by colleagues at Hopkins in the mid-2000s as being the anti-200-100 kilodalton antibody. They found it in the muscle specimens, was not seen in patients who did not have muscle diseases, did not routinely coexist with other myositis-specific antibodies. However, this antibody was also detected in younger myositis patients without statin exposure. What is the role of this antibody? We think it might be pathogenic. We do know that on muscle biopsies, there is a paucity of lymphocytes that infiltrate the muscle tissue. Also, MAC complexes indicating immune-mediated changes are occurring at the muscle cell membrane level. However, it is not routinely found on muscle cells. It could be, there may be an autoantibody not yet discovered that could be cross-reacting to an unidentified antigen. Who knows, that could be the case. The hypothesis is supported by observation that these antibody levels can correlate with CK and muscle weakness. What about treatment? We don't have clinical trials that are large or randomized that show what can work, but it's based on case series. We do know in these patients that 2 to 3 immunotherapy agents must be used as they seem to be refractory to standard care. And so these are some that are used, with rituximab being used for refractory cases. These patients also tend to relapse. What about newer treatments? There are many challenges to myositis management. These are rare disorders. Multiple organ systems may be involved. There could be slow response to therapy. We have few randomized controlled trials to support therapies, and so many treatments are off-label. These are some of the immunosuppressive therapies that have been used. What about the newer treatments? JAK inhibitors have been gaining more popularity over the last few years, starting with tofacitinib, and then now there are phase 3 trials looking at baricitinib and most recently brepocitinib. Linabacim is also finishing phase 3 trials. Expert opinion about treating dermatomyositis and having cutaneous disease. You can see here that it starts with topical agents and antimalarials, assessment at 1 to 3 months, and then second-line therapies if they are refractory to the first-line therapy. However, can we fit in JAK inhibitors? What about these JAK inhibitors in dermatomyositis? We think they're effective in dermatomyositis. They interfere with the JAK-STAT pathway. This is an intracellular signaling pathway. This pathway is involved in dermatomyositis pathogenesis via strong interferon activation that is overexpressed in muscle, serum, and skin. These responses are leading to impaired muscle repair and dysfunction, and with treatment become downregulated. First letter that came out to JAMA Dermatology in 2016 looked at tofacitinib and a few patients in their mid-30s and 40s who had refractory dermatomyositis. After 1 month, they had improvement with treatment. This led to an open label pilot study of 10 patients, again, a small study, but still was promising, and that it did show a significant change and improvement in skin disease. And when they looked at skin biopsies, there was a decrease in STAT1 signaling associated with suppression of the interferon. So conclusion of a longer-term extension trial stated that it was safe and well tolerated, and they did not see serious or adverse events. These data suggested that there should be more study. However, concerns are raised with JAK inhibitors. There are boxed warnings in the United States that in addition to infectious risks, there's a higher risk of thromboembolic events, malignancy risk, and a cardiovascular risk rate, or event rate is higher. What about linabacim? This is also being studied in phase 3 trials for the treatment of refractory cutaneous dermatomyositis. It targets a cannabinoid receptor type 2 and ultimately suppresses the TNF alpha inflammatory cytokines, interferon alpha, and beta production. This resolves with inflammation and fibrotic processes. It is not an immunosuppressant. It seems to be effective and safe with meaningful improvement in skin disease activity scores, perhaps even pain and physical function scores. There is a trial that had been presented at a EULAR conference several years ago. It looked at refractory dermatomyositis patients, a SMILE trial, and they received 2 escalating doses of linabacim and noted to have greater improvement compared to placebo in the skin disease activity scores. Tolerability was excellent. This large multicenter trial in the US has just closed, but data has not been released. So in summary, I discussed the 2017 EULAR ACR classification criteria for myositis is now being widely used by researchers and clinicians. I hope you took away from my talk that there is clinical heterogeneity existing among several different subtypes of myositis, including antisynthetase syndrome and necrotizing autoimmune myopathy. In particular, the HMG-CoA reductase necrotizing myopathy appears to be refractory to standard treatment. The JAK inhibitors are gaining popularity as effective for treatment of refractory dermatomyositis patients. I did not speak here about the interstitial lung disease trials with JAK inhibitors, but there are case reports stating also effective in that population of patients. Linabacim may be effective in cutaneous dermatomyositis, still being investigated, and the largest trial has just since closed, but data is not yet available. I thank you for your attention, and I'm honored to be here and can take questions.
Thank you so much for nice elegant presentation, inshallah. We have this concern about the dermatomyositis associated malignancies. When to suspect and what to screen?
Very good question. Thank you. Approximately 25% of patients with dermatomyositis have an occult malignancy. There are certain risk factors such as age, greater than 45 to 50, if they have constitutional symptoms, if they have a previous history of malignancy. We have also been risk stratifying according to myositis antibody presence, such as the TIP1 gamma antibody has a high odds ratio of malignancy association. If that antibody is seen in a patient newly diagnosed with dermatomyositis, then our practice here is to do CT scans of chest, abdomen, pelvis, or PET-CT at the time of diagnosis to look for malignancy.
That's nice. The last one is about the treatment of calcinosis associated with dermatomyositis.
That's a very good question as well. As we know, calcinosis is very difficult to treat, refractory. There are levels of severity as well with calcinosis, some being not mild and others being more severe. In our practice, we use topical sodium thiosulfate for these smaller calcinosis lesions present in the subcutaneous layer. However, the deep calcinosis is very difficult to target at times. There is thinking that calcinosis can respond to intravenous sodium thiosulfate. However, we haven't formally studied it at our institution. I know there had been a trial at the NIH studying the intravenous sodium thiosulfate, and I don't have that data available. We don't have any good treatments, unfortunately, at present for the calcinosis associated with dermatomyositis.
Yes, it is a real challenge.
Yes.
Thank you so much. Thank you so much for a nice presentation. And we hope to see you, inshallah, in the next symposium, inshallah, the next years.
Thank you very much.
Thank you so much. Thank you. We'll shift now to the third presentation in our symposium. My dear friend, Professor Dr. Mohammed Al-Umair, he is an assistant professor and consultant of rheumatology, Faculty of Medicine, King Saud University. Welcome, Dr. Mohammed. He will talk to us about rheumatoid arthritis, back to basics.
Thank you, Dr. Khalid, for inviting me to give this talk, and I hope to meet our colleagues again next year in face-to-face meeting. My talk today is going to be about some basic knowledge on rheumatoid arthritis pathogenesis. This is my disclosure. This is my agenda. So basically, rheumatoid arthritis is a chronic progressive inflammatory disorder associated with articular and extra-articular systemic effects. Rheumatoid arthritis is the most common chronic inflammatory arthritis with a reported prevalence between 0.5 to 1%. RA leads to joint destruction and physical disability, plus the development of multiple comorbidity, specifically cardiovascular disease, where it plays a major role in increasing the mortality rate in these patients. Now, when we look at RA pathogenesis, there are many important cells that play an important role, especially the T and B cell subtypes and the dendritic cells that orchestrate the development of the RA inflammatory milieu. Now, many pro-inflammatory cytokines are involved, specifically IL-6 and TNF-alpha, which do not only play a role in initiating the process, but also in maintaining inflammation and proliferation of the multiple cell lines. IL-1, IL-17 has been thought to play important roles theoretically, but when clinical trials have been done in IL-1 blockers and IL-17 blockers, the results were not as good as in blocking TNF and IL-6. Now we could see in this scheme where there is a difference between a normal joint and chronically inflamed RA joint with infiltration of multiple cell lines that play a role in maintaining this kind of inflammation and leading to the destruction. The synovium, which is extremely thin, becomes proliferative and develops what we call the pannus, which is like a tumor that invades the bone and develop joint erosions and destruction. Now, RA is a polygenetic disease. The genotype or the background genetics plays only 30% in development of RA. This is based on identical twin studies. More than 80% of RA patients have HLA-DRB104 background, but there are many other non-HLA genes like PTPN22, PADI4, and STAT4 SNPs. Now, the environmental factors, the two main environmental factors that have been identified as major factors for RA development include cigarette smoking and the P. gingivalis bacteria and the gum. But there are many new bacteria that have been associated with RA development, and again, the differences in the smoking device that may also play a role and has not been properly studied. Now, if you look at antibodies in rheumatoid arthritis, we have two main antibodies, the rheumatoid factor and the anti-CCP. Now, rheumatoid factors are a group of autoantibodies directed toward the FC portion of the IgG antibody. Most of them are IgM, but there are also IgG and IgA subtypes. Rheumatoid factors can be found in normal people, but also in many inflammatory and non-inflammatory conditions. Now, the normal function for the rheumatoid factors include enhancing immune complex clearance, helping B cells uptake complexes, and facilitate complement fixation by binding to the IgG containing immune complexes. So the rheumatoid factor has some normal role. Now, the autoreactive T cells are the major cell lines that drive the RA pathogenesis, which lead to activated B cells, which will lead into a process called affinity maturation, where B cells develop an uncontrolled level of production of pathogenic antibodies, including rheumatoid factors, which will again lead to some complex deposition, and then the cycle will be closed with more reactivation of autoreactive T cells. The anticyclic steroid peptide is an antibody directed against citrulline. It is more sensitive and specific than the rheumatoid factor. Similar to the rheumatoid factor, anti-CCP is associated with a more severe erosive disease. Now, citrullination is a post-translational modification of some amino acids. So arginine, with the help of the peptidyl arginine deaminase, transforms into citrulline, and lysine transforms into homocitrulline. And there are many targets for the ACPA testing, include fibrinogen, vimentin, type 2 collagen, and fibronectin, and the list is growing every year. Now, these autoantibodies can be present or identified in patients with rheumatoid arthritis prior to the development of the disease. This is a nice study that have been done on a blood bank, where they have evaluated the rheumatoid factor and CCP antibody presence in patients who donated blood more than 15 years prior to the development of the rheumatoid arthritis. And you could see that the closer the patient comes toward the disease, the higher the antibody development. Now, if you look at the pathogenesis of RA, you have a genetic background, you have some environmental risk factor, which will develop these autoantibodies. And then these patients might go into an early non-specific disease with arthralgia. These patients might be diagnosed initially as undifferentiated arthritis, and then they go into the full-blown polyarticular rheumatoid arthritis. Or some patients might move directly from the arthralgia to a full-blown rheumatoid arthritis. And again, this cartoon will show you how all of these factors combine together to lead to the final presentation of rheumatoid arthritis with all of its consequences. And this review shows you how different parts of the immune system have been involved in the development of rheumatoid arthritis, including the adaptive immunity, the innate immunity, the stromal pathway with the fibroblast like synovostite activation as one of the most important factors in RA pathogenesis, and of course the systematic pathways which include metabolic syndrome, development of osteoporosis, and other factors. Now, joint damage starts with autoimmunity inflammation. Then you have damage that causes disability. Now, if we can differentiate disability into two different parts, reversible and irreversible, and the damage into joint erosion and joint space narrowing. This is the pre-RA phase. If we could treat it, identify it, and this again still part of clinical trials, not part of the practice, but early identification will lead not only to better outcome, but also to a higher rate of drug-free remission. Now, if you control inflammation, this will control the reversible disability and will prevent damage and the irreversibility. The role of disease-modifying agents, whether they are biological or non-biological NMARDs and the small molecules, is to stop the inflammation and repair the defects in the immune system and prevent the joint damage. Drugs like denosumab, who have been tried solely on RA, have been shown to reduce the joint damage, but not to control the disease. Now, the mechanism of joint damage is very complex. We have two areas that are important inside the joint. We have the cartilage Panus junction and the non-cartilage Panus junction. So basically, the cartilage Panus junction is the area where the Panus is invading the cartilage and causing damage, while the non-cartilage Panus junction is a far area from the cartilage and plays the most important role in driving the inflammation. If we look at the two areas, you have different cell lines. So in the CPJ, you have activated macrophages, you have fibroblasts-like synovosites, you have few dendritic cells, few T and B cells, and you have mainly TNF, IL-1, and IL-6. Now, this cartoon shows you the distribution of these cells. So you could see here, it's mainly played by innate immunity, dendritic cells, T and B cells, while here you have mainly part of the adaptive, this is the adaptive immunity with T and B cells and dendritic cells, while here you could see mainly part of the innate immunity. So this is like the leadership of the army, and these are the regular soldiers. And again, this cartoon have shown us 2 decades ago the different types of cells at the cartilage Panus junction with mainly macrophages. Now, the non-CPJ, we have similar lining, but you have more T cells, B cells, and dendritic cells, and you have different mediators. And here, when you see the non-CPJ, you can see mainly CD3 positive T lymphocytes, which drive the inflammation. These are the main major players. Now, erosion is a different story. You have 2 important mechanisms. You have the osteoclast activation and the synovial fibroblast secreting DKK1 and cyclostatin, which inhibit osteoblast. You have osteoblast activation, you have and you have osteoblast inhibition. The joint space narrowing can happen due to the damage of the development of the erosion, but also joint space narrowing can happen in RA patients and other inflammatory arthritis by the degradation of the cartilage by metalloproteinases. These are the 1987 rheumatoid arthritis classification criteria, and these criteria are very specific. You will see joint damage, you will see rheumatoid nodules, and these are all signs of chronic, poorly treated rheumatoid arthritis. Now, with the development of the new criteria, which has passed a full decade of its use in daily practice, you could see that it has allowed us to diagnose many patients with an earlier onset and to have the treat to target strategy, which allows these patients to go into better remission. Now, these are important points to remember, because whenever you look at the classification criteria, this is the table you look at, but these are the explanation that many people do not look at when they see these tables. And there is another algorithm to look at rheumatoid arthritis probability in a patient presenting with inflammatory arthritis. So the higher the joint number involvement, the smaller the joints, the availability of seropositivity, acute phase reactant, and increased duration, all will lead to an increasing point, and this will help you to put a probability this patient might have rheumatoid arthritis. And as you have heard from the previous presentation, many patients present with inflammatory arthritis, and if rheumatoid factor and CCP are negative, these patients might be seronegative rheumatoid arthritis, might be spondyloarthritis patients, might be systemic sclerosis, myositis, or even CPPD disease. So it's important to identify these patients, treat them adequately, and follow them up if they have a seronegative disease. So in conclusion, rheumatoid arthritis is a multifactorial disease that leads to significant morbidity and mortality. There is a complex involvement of many components of the immune system, especially the adaptive immunity. And increasing knowledge have allowed us to develop many of the biologics and small molecule in the treatment of RA and prevention of disability. And of course, the new classification criteria have better sensitivity, and fulfillment might happen over time if patients are coming with undifferentiated manifestation early. Thank you.
Thank you so much, Professor Mohammed. Very nice presentation. Basics are so important to understand the nature of the disease and to develop more medications. Thank you so much. We have a question regarding the value of repeating anti-CCP antibodies in patients already diagnosed as RA. Is it of value?
Now, if a patient has been diagnosed with rheumatoid arthritis with a positive CCP or positive rheumatoid factor, there is no clinical value to repeat these antibodies. Now, some patients might seroconvert with treatment to negative, especially with drugs like rituximab and abatacept. And some patients with seronegative rheumatoid arthritis might seroconvert to positive after 1 or 2 years of follow-up. If a patient has a positive antibody from the beginning, the use of these antibodies is only for diagnosis rather than follow-up.
That's true. It's not related to the disease activity.
Yes.
Thank you. Thank you so much. A really nice presentation from a nice friend. Thank you, Professor Dr. Long. Thank you. Thank you so much. جزاك خير. نفع الله بكم. We'll shift now to the fourth presentation, our symposium. My dear great professor, Professor Dr. Abdul Azim Al-Hafni, he is the professor of internal medicine, immunology, and rheumatology. He is in the faculty of medicine at Shams University, Cairo, Egypt. Professor Dr. Abdul Azim is my dear supervisor for many theses, and it's our honor and pleasure to have you in every symposium. Welcome, Dr. Abdul. You can unmute from your side.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا رسول الله. السلام عليكم ورحمة الله وبركاته. الحمد لله الذي هدانا لهذا وما كنا لنهتدي لولا أن هدانا الله. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما وانفع بنا خلقك جميعا. It is my pleasure to join you in this very elegant symposium. It is growing every year and I am the honor to share it from the first beginning and to watch it when it is growing up to this very fantastic level. And I expect it will be an international symposium very soon. شكرا للأستاذ الدكتور خالد فتحي على الدعوة الكريمة، وبشكر الأورجنايزنج كوميتي والسعوديان جيرمان هوسبيتال على تنظيمها ودعوتنا لهذا الحفل العلمي الجميل. My presentation today is about EGPA, eosinophilic granulomatous. كده السكرين شيرد كده دكتور خالد.
Yes, you can see.
Eosinophilic granulomatosis with polyangiitis is one of the uncomplicated vasculitis and eosinophil-rich necrotizing granulomatous inflammation mainly affects the small to medium-sized blood vessels. Asthma, eosinophilia, and peripheral neuropathy are common clinical manifestations. Only about 40% of patients have the perinuclear anti-neutrophil cytoplasmic antibody, also anti-myelobase MBO antibody. The triggering factors may be the exposure to different allergens, infections, vaccinations, drugs, and silica exposure. Regarding vaccination, the COVID-19 vaccination can induce or trigger the eosinophilic granulomatosis. When to suspect ANCA-associated vasculitis, if there is pulmonary renal syndrome, mononeuritis multiplex, and/or palpable berberic eruptions. The prevalence is very small, but it is nowadays we can see it frequently because of the vaccination and the disease of the coronavirus. 10 in every million, male to female equal, mean age at the diagnosis 50 years. It develops into 3 phases. The first phase is the allergic phase, including manifestations of asthma and/or allergic rhinitis, nasal polyposis, and/or allergic sinusitis. The second phase is the eosinophilic phase with high eosinophilia, often accompanied by pulmonary infiltrates. And the last phase is the vasculitic phase with peripheral neuropathy and systemic constitutional symptoms, which may appear within 3 years after the onset of asthma. The main manifestations is a dermatopulmonary renal syndrome, which are the feature of this disease. In addition to asthma, eosinophilia, and peripheral nerve involvement are the most common manifestations. Constitutional symptoms which may appear later in the course of the disease, including malaise, fatigue, flu-like symptoms, weight loss in 70%, fever, myalgia with berberic eruptions. Respiratory manifestations is the most common with the patient suffering from asthma, which is the central features of eosinophilic granulomatosis with polyangiitis, occurring in about 97% in patients. It is late on severe persistent asthma and difficult to treat with pulmonary infertility. عشان كده لو في حد جالنا with bronchial asthma عادية ولكنها late in onset and severe and persistent, we have to consider in the differential diagnosis this eosinophilia with polyangiitis. Allergic rhinitis also occurs with recurrent sinusitis in about 60% of patients and nasal polyposis. Cough with hemoptysis in about a third of the patients due to pulmonary alveolar hemorrhage, due to alveolar capillaritis, which may be life-threatening if not treated urgently. The skin manifestations in 60% and include leukocytoclastic vasculitis with palpable berberic eruptions, livido reticularis, urticaria, and subcutaneous may be progress to digital ischemia, skin necrosis, and gangrene like these pictures. The typical skin rash starts with petechial eruptions, evolves to palpable berberic eruptions, which does not blanch when we pressure on it, central necrosis, hyperpigmentation as it resolves, mainly affecting in the dependent areas like the legs, usually worsen with prolonged standing, and may become bullous, necrotic, and or ulcerate. The vasculitic peripheral neuropathy may be, or the most frequent form is mononeuritis multiplex, occurring in about 77% of the patients, with multiple nerves in random areas of the body that can be affected in a stepwise progressive pattern, leading to painful asymmetric sensory and motor neuropathy. Some patients have a distal symmetric sensory motor axonal polyneuropathy. Other signs and symptoms includes cardiovascular involvement with myocarditis, pericarditis, congestive heart failure, with subendocardial fibrosis, myocardial infarction, secondary coronary vasculitis, renal involvement leading to hypertension, and signs of uremia and advanced renal failure in a minority of cases, gastrointestinal involvement in about a third of the patients, with abdominal pain, diarrhea, and gastrointestinal bleeding, bowel ischemia or perforation, gastrointestinal vasculitis, eosinophilic gastritis or eosinophilic colitis, appendicitis, pancreatitis, and in 40% of patients suffering from arthralgia. Workup, the diagnosis is strongly supported by typical clinical picture, as we said, or biopsy showing small or medium-sized vasculitis with eosinophilic infiltration, or both. Other workup, CBC with differential, typically demonstrates eosinophilia. Usually, eosinophils demonstrates more than 10% of the total leukocytic count, more than 500 to more than 10,000 eosinophils per microliter, and anemia. When the eosinophils increase in number, if it is between 500 to 1,500, it is mild eosinophilia. Moderate when more than 1,500 to less than 5,000. Severe when the total count is more than 5,000 per microliter. ESR and CRP usually elevated. In patients with the renal involvement, the BUN and the creatinine level are elevated. Urine analysis shows active urinary sediments with the presence of proteinuria, microscopic hematuria, and red blood cells. Perinuclear anti-neutrophil cytoplasmic antibodies are present in approximately 40% of cases. It is not diagnostic. It is sensitive but not diagnostic. Elevated serum IgE hypergammaglobulinemia and rheumatoid factor at positive at low titers may be seen. With bronchoalveolar lavage, eosinophilia is evident in about third of patients. ANCA testing with two approaches. In direct immunofluorescence, we see the pattern of ANCA, either cytoplasmic or perinuclear or atypical, or by ELISA, which detecting the antigen, either PR3 antiproteinase 3, which is the cytoplasmic anti-neutrophil cytoplasmic antibody, or the perinuclear showing the MPO, which is the anti-myeloproteinase antibody. ANCA, or the anti-BR3, anti-proteinase 3, present in about 80 to 90% of patients with vaginal granulomatosis with polyangiitis, and the perinuclear, which is the myeloperoxidase antibody, is present in 80 to 90% of microscopic polyangiitis, and in about 40% of our cases with Sharp-Strauss or eosinophilic granulomatosis with polyangiitis. ANCA positive patients had significantly higher incidence of renal involvement, skin involvement, and mononeuritis multiplex at the time of diagnosis. Also, positive patients with ANCA required frequently higher steroid doses to maintain remission, while ANCA negative patients had significantly more frequent cardiac involvement. Imaging studies shows the chest radiography shows pulmonary opacities can be found in tilt to 2/3 of the cases. Localized infiltrates usually are bilateral, peripheral, patchy, and may be transient. Extensive airspace opacities with drop in hemoglobin suggestive of intra-alveolar hemorrhage with bleeding that result from the pulmonary alveolar capillaritis, which is, as we said, life-threatening situation if not treated urgently. And the hemoptysis in these cases is present only in about up to 66%, not in all cases. And so these patients have to be treated aggressively in ICU, in chest ICU, and monitored carefully. Pleural effusion are observed from 5 to 30% of cases and can be eosinophilic. The high resolution CT still late and negative. Other tests, we have to do ECG echocardiography to exclude the cardiac involvement. Gastrointestinal endoscopy when there is GI bleeding or GI severe symptoms. EMG and nerve conduction study for peripheral neuropathies. Histologic features: small necrotizing lung granulomas composed of central area of eosinophilic core surrounding radially by macrophages and epithelioid giant cells, like this picture. Glomerulonephritis is not as common or severe as in Wegener, but it is less severe and without significant deposition of immune complex called BOCI immune. So the eosinophilic granulomatosis with polyangiitis, which was called Sharp-Strauss, composed of asthma, allergic rhinitis, eosinophilia more than 10% of the total leukocytic count, pulmonary infiltrates, mononeuritis multiplex, or peripheral neuropathy. ACR and EULAR release validated classification criteria for ANCA-associated vasculitis, And regarding the eosinophilic granulomatosis with polyangiitis, there is consideration with applying these criteria when the diagnosis of small or medium-sized vasculitis has been made, and excluding the mimicking vasculitis. So we have to have clinical features, obstructive airway disease in about and it takes score 3. Nasal polyps takes also score 3, and mononucleus multiplex score 1. Laboratory and biopsy criteria: when there is serum eosinophils, high serum eosinophils, more than 10,000 or equal to 10,000, it takes score 5. Asthma score 5. Nasal polyps score, as we said, score asthma score 3, nasal polyps score 3, eosinophil in biopsy score 2, mononucleus multiplex score 1. But when there is PR3, which is C-ANCA, positive in this patient, we have to subtract 3 from the score, from the total score, because it is mainly in Wegener's granulomatosis. When there is hematuria, evident hematuria, also because it is more common in microscopic polyangiitis and in Wegener, we have to subtract 1. So if the total score is 6 or more, this is satisfactory for classification of granulomatosis with polyangiitis. The differential diagnosis: asthma without granulomatosis, eosinophilia due to other causes, manifestations, or like some like this, hypereosinophilic syndrome, infective endocarditis, leukocytoclastic vasculitis with skin changes, Goodbachar syndrome, eosinophilic gastroenteritis, bacterial pneumonia, cryoglobulinemia, granulomatosis with polyangiitis اللي هي Wegener, anti-glomerular membrane disease, crescentic glomerulonephritis, microscopic polyangiitis, polyarthritis nodosa, and acute mesenteric ischemia. All these we have to think in when before we diagnose the patient as EBGA. There's also drug-induced ANCA-associated vasculitis. The drug-induced ANCA-associated vasculitis was considered to be serious in most of the cases, and even proved fatal in about 9% of patients. Hydralazine, propyl thiouracil, carbimazole اللي هو انتي ثايرويد, sofosbuvir anti for treatment of hepatitis C, minocycline antibiotic, nintidibine, nintedanib for interstitial pulmonary fibrosis, were associated with highest disproportional reporting for ANCA secondary يعني أو drug-induced ANCA-associated vasculitis. In 2021, the SCR Vasculitic Foundation guideline for management of ANCA-associated vasculitis, with the treatment goals of patient survival, induce remission and limit organ damage. This is the goals for treatment. Maintain remission and avoid relapses. Manage treatment-related toxicity and improve patient quality of life. لازم أعرف أنا عشان في قسمنا الديزيز according to its severity, organ or life threatening disease. لو في alveolar hemorrhage, لو في glomerulonephritis أو cardiac involvement, أو لو في in cases of mononucleus multiplex أو CNS affection, or in the presence of mesenteric ischemia or digital ischemia. These situations called organ or life-threatening disease. When there is non-organ threatening disease like sinusitis, lung nodules, vertebral or arthralgia, the treatment will differ exactly. And also, if there is active disease, which is defined as new, persistent, or worsening clinical manifestations due to ANCA-associated vasculitis and not related to prior damage. So we have to categorize the patient if he has active, severe, or organ-threatening vasculitis, eosinophilic rheumatoid meningitis. We have to give as induction treatment pulse intravenous corticosteroid or high dose daily oral corticosteroid, then induction with cyclophosphamide or rituximab. If there is remission on cyclophosphamide or rituximab, we have to switch to methotrexate or azathioprine or MMF as maintenance therapy. When the severe disease relapse after remission with cyclophosphamide or rituximab, we have to give again pulse intravenous or high dose oral daily corticosteroid with pulse rituximab again. The duration of glucocorticoid therapy should be guided by the patient's clinical condition والvalues بتاعت follow up investigations والpreferences بتاعت الحالة. For remission induction, we have to give, as we said, intravenous pulse glucocorticoid, intravenous methylprednisolone from 0.5 to 1 gram per day for 3 to 5 days, or high-dose oral glucocorticoid prednisone or prednisolone 1 milligram per kilogram per day up to 40 milligram per day for 3 weeks, and cyclophosphamide up to 2 milligram per kilogram orally daily for 3 to 6 months, or intermittent 15 milligram per kilogram intravenous infusion every 2 weeks for 3 doses, then every 3 weeks for at least 3 doses again in adult cases. Or rituximab, the vasculitis dose, 375 milligram per meter square intravenous infusion weekly for 4 doses, or 1 gram intravenous infusion on day 1 and after 2 weeks. Methotrexate up to 25 milligram per week, subcutaneous or oral, or azathioprine up to 2 milligram per kilogram per day, or mycophenolate mofetil up to 1,500 milligram orally twice per day. This is options for remission induction. Keep in mind when to choose rituximab or when to better to choose cyclophosphamide. Rituximab is preferred for children and adolescents and frail older adults, premenopausal women and men concerned about their fertility. Glucocorticoid, it has glucocorticoid sparing, especially important. And it can be used also in cases of relapsing disease and when the PR3 was positive يعني في الفاجنال. Cyclophosphamide preferred when rituximab difficult to access due to any factor, economic or others, or when there is severe glomerulonephritis, especially when serum creatinine more than 4 at diagnosis. The combination of 2 intravenous pulses of cyclophosphamide with rituximab can be considered by some authors. Cyclophosphamide can carry substantial risk of neutropenia, toxicity, and small but potential risk for infertility in young females, especially. Addition of sotrim for prophylaxis to prevent hemocystic gyrophysae pneumonia is important. Regarding the active non-severe or non-organ threatening EBGA, options here in order of favored recommended. أول حاجة أحسن حاجة الجلوكوكورتيكويد مع الميبوليزوماب، ده انتي انترليوكين 5 انتي بودي، مونوكلونال انتي بودي، او الجلوكوكورتيكويد مع الميثروكسيت او مع الازاسابرين او جلوكوكورتيكويد مع الام ام اف، دول كلهم في كاتيجوري واحد، ده او ده او ده، او الجلوكوكورتيكويد مع ريتوكسيماب او سايكلوفوسفامايد لو كانت بقى مور سيفير كيس. الجلوكوكورتيكويد الون ان سيلكتد بيشنتس. لو النون سيفير ديزيز ده حصل منه ريلابس على الميثروكسيت او الازاسابرين او الام ام اف او الستيرويد الون، ولو معاه هاي سيرم اي جي اي، في الحاله دي بقاد جلوكوكورتيكويد والميبوليزوماب. طيب لو النون سيفير ديزيز ده ريلابسد مع بقى الميبوليزوماب او مع ريتوكسيماب اللي هم يعني الحاجات القويه اللي عندنا، نعمل ايه؟ يبقى كونسيدر ديفرنت اميونو موديولاتوري ابروتش. وهنا نجرب الاوماليزوماب اللي هو الزولير، اللي هو binds to IgE prevents its binding to mast cell. وناخد بالنا ان الريسك اوف ريلابس هنا عالي، بالذات ان عندهم انكا بوزيتيف كيسز 40% ممكن يحصل لهم اتليست 1 ريلابس during their فولو اب. ونخلي بالنا ان الريلابس ده بيحصل بالذات يعني لو الانكا بوزيتيف. اما بيحصل سويتشنج من الانكا بوزيتيف الى نيجاتيف بيبقى في الغالب الريلابس اقل. هو ادي الريلابس بالخط الاسود المستمر ده، والثاني بالدوتد يعني بيبقى الريلابسز بتبقى اكتر في حالات الانكا بوزيتيف من الحالات الانكا نيجاتيف. وريلابس يعني ريكارنس اوف اكتيف ديزيز following a period of remission، وده اللي احنا مش عاوزين نوصل له. كذلك المينتنس بالريتوكسيماب الريلابسز اقل بكتير لو عملنا مينتنس بالازاسايوبرين. ناخد بالنا من الجلوكوكورتيكويد توكسيستي اندكس اللي احنا بنستخدمها كتير قوي، وناخد بالنا انه الجلوكوكورتيكويد لابد ان احنا نوصل للتارجت ان احنا نقلل الدوز و as soon as possible. ما لو نعرف نوقفه يبقى افضل، ونوصل للليست افكتيف دوز، لان الكورتيكوستيرويد له حاجات كتيره جدا ريليتد توكسيسيتيز، من اول الاوستيوبروزيس والدايابيتس والكاتاراكت والماسل ويكنس واتروفي والكارديو فاسكولار ايفنتس مايوكارديال انفاركشنز والفاسكولار نيكروزيس، دول بعض من الحاجات. وبالتالي البيكسي فاز ترايل يعني طلعت لنا بالريكومنديشن ان احنا ممكن we can decrease the dose even to half the dose of corticosteroid without significant difference in serious adverse events. وكذلك السيريس انفكشن ممكن يقل بعد سنه، ولكنها non significant decrease in infection rate. الديزيز مونيتورنج، بنعمل مونيتورنج للديزيز كلينيكالي تو فور ريتيرنينج اوف ديزيز اكتيفيتي، يعني لو في اي ريلابس نكتشفه as soon as possible we can detect any relapse, and also to detect any drug toxicities and any comorbidities. الاسنوفيليك كاونت والاي اس ار والسيرم كرياتينين ويورين اناليسيس should be performed regularly to assess this activity and to detect renal affection. ANCA testing has a value in diagnosis and prognosis, but not in follow-up of disease activity in most of the author opinion. Dose of rituximab and or cyclophosphamide and a high dose of glucocorticoids, which while this regimen is highly effective for disease control, there is concern regarding the rate of adverse events, particularly infections, generally attributed to the use of glucocorticoids. Bexy-Vaz trial has demonstrated that we are able to use fewer glucocorticoids, even the half dose used in the past, but concerning rates of infection remain an issue. With the new lines of therapy by interleukin-5 blocker, nivolizumab, and IgE blocker, omalizumab, اللي هو الزولير, EBGA patients gained very interesting options for remission. Lastly, the natural history of many of the systemic vasculitis is rapidly progressive or relapsing, and they may be fatal without early treatment. In this regard, timely diagnosis of vasculitis is crucial because of the vital role of early immunosuppressive therapy in preventing multi-organ damage and decreasing morbidity and mortality rate. وشكرا جزيلا. دي حفيدتي ريم محمود، وربنا يكرمكم، ومتشكر جدا على الاستماع.
ما شاء الله لا قوة إلا بالله، ربنا يحفظها يا رب.
لا عاوز عريس بس يعني عنده عريس طبعا ده ما شاء الله.
ربنا يحفظها يا رب.
الله يكرمك.
A very nice presentation about a very hard topic, the pulmonary renal syndromes. We have concern about does the plasma exchange has a role in management?
Plasma exchange، ويعني دلوقتي ما بيحبذوهاش، ما لولهاش الرول اللي كان متوقع من قبل كده، وبالتالي هم ما حطوهاش في الريكومنديشن. كانش الفاسيلتي كافيه.
خرجني.
ايوه
السلام عليكم.
عليكم السلام ورحمه الله وبركاته.
معلش هو خرجني. طب the last one about management of relapses. What do you recommend?
أيوة. لابد اثناء الفولو اب يكون احنا عينينا على العيان من ناحيه الكلينيكال ومن ناحيه اللاب، بحيث الميتيكولوس يدينا فرصه ان احنا تو ديتكت as early as possible الريلابسز، وبالتالي التريتمنت ممكن يكون اسهل وافضل كتير قوي. وزي ما الاستاديز قالت لنا انه المينتننس اوف ثيرابي افضل بالريتوكسيماب، افضل منه بالحاجات الثانيه. ان احنا هنستخدم ممكن اب تو 40% الريلابس ريت يحصل، وبالذات الناس اللي ما حصل لهمش سويتش من انكا بوزيتيف الى انكا نيجاتيف. لو الامور بسيطه والعيان ستيبل يبقى انا ممكن استخدم الحاجات المور سيمبل، مش لازم بقى ريتوكسيماب، ممكن الحاجات السيمبل جلوكوكورتيكويد مع ميثوتريكسيت مع ازاسابرين مع MMF حسب الكيس وحسب الفولو اب اللي انا طلعت بيه من العيان.
Nice, very nice presentation. Thank you, Professor Fadl Adim. Nice presentation as you. Thank you so much. We'll shift now to the fifth presentation in our symposium. We have a very nice and elegant figure in our symposium we are proud of. Dr. Hanan Al-Rais, she is the president of the Saudi Society of Rheumatology. Dr. Hanan, the senior consultant rheumatologist, the deputy director of the medicine department, and the director of the Rheumatology Fellowship in Prince Sultan Military City, and she is also assistant professor in King Faisal University. Welcome, Dr. Hanan. Dr. Hanan, thank you so much for your presence in every year symposium. We are proud of you.
السلام عليكم ورحمة الله. صوتي سامعينه؟
Yes. أيوة. عليكم السلام ورحمة الله وبركاته.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. To start with, I would like to thank Dr. Khalid and the whole organizing committee for inviting me to be part of this actually prestigious conference. And I would like to congratulate you actually for this continuity of work in a yearly basis. And every year I found more and more attractive topics and speakers. Just for the sake of the time, my topic today is about rheumatic disease and pregnancy. Of course, it's difficult to cover all the rheumatic disease and pregnancy. We will try to go through the main important topic, aspect in this topics, which is, I don't know why it's not coming. It's not coming. It's okay. Oh, okay. So the most important thing in these patients, the autoimmune disease, autoimmune rheumatic disease, because as you know, that autoimmune diseases primarily affect women at their childbearing age. And usually, if it is active disease, and some of these autoimmune disease might affect or might lead to serious maternal and fetal adverse outcome, where we count this disease as high-risk pregnancy. In the coming 20 minutes, just we'll see what risk factor, if it is present, make these diseases risky and how to avoid it. We face a lot of things, being most of those patients are young, and they used to ask us, even from the first visit, whether this disease affects their fertility, what type of contraception they can use and safe for them, and what medication can be used during pregnancy and lactation. That's why counseling is very important in these patients from day one, from visit one. When we talk to the patient, we have to inform them about the safety of the medication, about the importance of avoid the pregnancy while they are active disease or in medication which is risky for the fetus. I will try to cover a few points about the effect of pregnancy on different rheumatic diseases, but we'll concentrate mainly on lupus and antiphospholipid. Then, if there is time, we'll talk about neonatal lupus. And these here, the evidence-based reference for those who want to know from where I took my presentation. As I mentioned, pre-conceptional counseling is essential, and fertility is one of the major concerns to our patient. We have to know and to inform the patient that autoimmune disease or rheumatic musculoskeletal disease patients, they are as fertile as general population if they are stable and in stable medication, especially if they are inactive or in steroid dose like 5 milligram or less than 20 milligram. The low fertility rate can be seen if patient active, or he is, because of the activity, he is on steroid more than 20 milligram. If there is renal involvement, like moderate to severe renal involvement, this will affect the fertility. And some of the medication, if the patient took medication like cyclophosphamide that affect the ovary and causing premature ovarian failure, if it is used for a long time with high accumulative dose, it can affect the fertility. So even before starting this type of medication, we have to inform the patient, and we have to save the ovum if the patient have her age above 30 or she has not enough kids in the family. For cyclo to affect the ovary, it's usually, as I mentioned, is age dependent as well as dose dependent. So premature ovarian failure occur mainly for those above 30, and less commonly in those less than 25 years old, and the cumulative dose, of course. So what to do for this patient? The best way is to use gonadotropin-releasing hormone as a protective. It is given like subcutaneous monthly in any patient, if patient for cyclophosphamide. So we use to give it just prior to give the cyclophosphamide, and this study showed that those patients who used gonadotropin-releasing hormone, the premature ovarian failure developed only in 5%, which is 1 out of 20 patients, compared to those without using gonadotropin-releasing hormone. The risk of premature ovarian failure is 30%. So consider this opportunity in a patient who wish to get pregnant and there is a need to give cyclophosphamide. So what other counseling, important counseling to this patient? Let us taking a scenario, a case scenario. Here is a 26 years old woman diagnosed as systemic lupus erythematosus 10 years back. She got previous class 4 glomerulonephritis, and that lady treated with mycophenolate for 6 years. So now her creatinine is 2.5 with creatinine clearance 22. She got quiescent disease regarding her lupus, and she's only now in hydroxychloroquine. Her antiphospholipid antibody, anti-Rho, anti-La were negative. So what is your advice for such a patient? So she's in quiescent, she's inactive, she's in safe medication, which is hydroxychloroquine, but she got element of renal failure with a creatinine of 2.5 and low creatinine clearance. So such a patient is risky for pregnancy. So some of the disease-related damage, whether it is systemic lupus or vasculitis or other rheumatic disease, if they have severe renal or cardiac or pulmonary insufficiency, so these patients should avoid pregnancy. Severe valvular heart disease, whether it is related to the disease or rheumatic heart disease, again, is contraindication for pregnancy. Severe pulmonary hypertension, uncontrolled hypertension, and history of cardiovascular or CVA or MI. What option for this patient with chronic renal failure? The option for this patient is to wait for renal transplant. So usually the patient can get pregnant post kidney transplant, like 1 year after kidney transplant. So we thank God that for the last maybe 40 years, with a significant improvement in management of patients with autoimmune disease, there was a decline in the pregnancy loss rate in patients with SLE and other autoimmune diseases. So SLE pregnancy are still at high risk of spontaneous abortion, preeclampsia, IUCD or intrauterine growth restriction, fetal death, premature delivery, cesarean delivery, but with specific risk factors. So not for all patients. It's mainly for patient with, as I mentioned, with patient with active lupus nephritis or previous lupus nephritis with some renal impairment. In those with positive antiphospholipid antibodies, patient with active disease at conception. That's why we have to ensure that patient with autoimmune disease, SLE, other rheumatic disease, planning to get pregnant, should be with inactive disease or low disease activity with a steroid of 5 milligram and on a safe medication prior to pregnancy. So at least 3 to 6 months. One of famous study published in 2015, which is PROMISE study, is one of the largest prospective study to date. It investigates pregnancy in systemic lupus erythematosus. And in this study, actually, they exclude patients with active nephritis or with proteinuria more than 1 gram or with prednisone more than 20 milligram. And they include patients with and without antiphospholipid antibodies in this cohort, this multi-center, more than 10 international center. And they found that in patients with no risk factor at baseline, the adverse outcome rate was 7.8% for fetal and neonatal, and the fetal neonatal mortality was only around 4%. And the predictors for adverse pregnancy outcome, which is the adverse pregnancy outcome preeclampsia, like preeclampsia, active disease, and so on. The predictor was mainly maternal disease activity, as well as the presence of lupus anticoagulant carry very high risk for adverse pregnancy outcome, reaching to up to 58%, and for the fetal and neonatal mortality reaching to 22%. Other important risk factors are hypertension during pregnancy. Other studies in pregnancy in lupus, and this cohort published in 2006 from John Hopkins by Professor Petrie, and they found that around 16% of this pregnancy ended with pregnancy loss. So we have to inform our patients that if they have one of these risk factors, they might end with pregnancy loss, preeclampsia, other active lupus during pregnancy, and it can harm the mother and the fetus, especially the first trimester proteinuria, which is more than 500 milligram in the first trimester. If there is antiphospholipid, as I mentioned, presence of thrombocytopenia and hypertension. Another survey of 4,000 lupus pregnancy, and they found that patients with lupus, regardless of the activity, they found compared to healthy population, they have longer hospital stay, increased probability to have hypertension, high rate of intrauterine growth restriction, as well as increase of cesarean section. In a subsequent study using the same database published in 2008, they found that also there is increased threefold increased risk of preeclampsia and 20% increase in maternal death. And all of this was mainly in those with hypertension during pregnancy and nephritis with the presence of antiphospholipid antibodies. So counseling of these patients, very essential. We have to treat for stable disease 4 to 6 months. Be sure that the patient quiescent or inactive before conceiving, because sometimes when we shift the medications, for example, the MMF to Imuran, and observe the patient, they might have activity. So we have to inform the patient to avoid pregnancy, to continue the contraception at least 3 to 6 months, to be sure that while they are on the safe medication, they are in quiescent disease. We have to check for the antibodies, the antiphospholipid antibodies and anti-Rho antibodies. And this was there in the guideline for management of patients with autoimmune disease published the last ACR guidelines. So counseling is very essential, and you can see this one, which is published in arthritis care research, as well as in arthritis and rheumatism. And so counseling is essential. When any patient consider pregnancy, assess the disease activity. If it is high disease activity, treat to control the disease and reassess, and then you can advise for to have a pregnancy. If it is low disease activity, change to pregnancy compatible medication and observe the efficacy at least 3 to 6 months, and then assess the patient early in the pregnancy. And the advice to do for all patients planning to get pregnant with autoimmune disease, anti-Rho antibodies as well as antiphospholipid antibodies. So in SLE patient, if they are on stable in hydroxychloroquine, there is strong recommendation to continue the hydroxychloroquine, and the data showed if you continue taking the hydroxychloroquine, the risk of abortion and having an active disease much less. And if patient not on hydroxychloroquine, start patient on hydroxychloroquine again, because it's good to control the disease and to prevent having an active lupus during pregnancy. If patients have positive anti-ROM, even in absence of SLE or non-SLE, we have to give hydroxychloroquine and to do serial fetal echo. We'll talk about this when we talk about neonatal lupus. So if a patient have positive antiphospholipid antibodies, then the recommendation, even without syndrome, so just an antibodies, it's better to start, and it is a strong recommendation. The dark green indicates strong recommendation to give prophylactic aspirin or heparin if there is contraindication for aspirin, but usually low dose aspirin is enough. If patients have antiphospholipid syndrome, which is antibodies plus thrombotic event, then therapeutic heparin should be advised with hydroxychloroquine. So in a patient who has active disease and in a medication which is not safe during pregnancy, so we have to advise for contraception. Then what is the safe contraception for this patient? We have to assess for any patient with autoimmune disease, because the antiphospholipid antibodies, the percentage in SLE patient reaching up to 30%, and secondary antiphospholipid with Sjogren as well as with other autoimmune disease, it can reach up to 20%. So it's better to assess for the presence of antiphospholipid before starting contraceptive pills, hormonal therapy. If it is positive antiphospholipid antibodies, then the best option for them intrauterine device, IUDs, and we can use progesterone only pills if there is contraindication for IUD. We have to avoid the combination estrogen or progesterone, because it can cause thrombosis in a patient with positive antiphospholipid antibodies. If the result of antiphospholipid antibodies negative, whether SLE or non-SLE, we can advise for IUD, which is #1. But again, progesterone alone, combined estrogen and progesterone is safe in these patients, since there is no antiphospholipid. What medication is safe during pregnancy? Always we face that our patient afraid, and when they get pregnant, if we didn't counsel them rightly, they stop everything. They stop all the medication and they became active because they are afraid from the treatment. So we have to inform them about that some medication is very safe and they can continue on it. Let us take this scenario: a 36 years old woman with a history of class 4 nephritis. She's an MMF for 3 years, and then she's planning to get pregnant, and she's in remission regarding her nephritis. So we change her to azathioprine. While she's on azathioprine, 4 months later, she developed a renal flare while she's on Imuran. So what is your advice for this patient? Of course, we have to treat the activity. We have to put her back in the MMF, observe further, and then when we consider again, when she come back to remission, then we will consider whether to give azathioprine or combination azathioprine and tacrolimus. The most important thing is to keep our patient in remission prior to conceive. So here in the guideline of the American College of Rheumatology, strong evidence indicate that hydroxychloroquine is safe during pregnancy, pre-pregnancy and breastfeeding, sulfasalazine, colchicine, as well as azathioprine. So all these 4 medications are safe pre-conception and during pregnancy. The azathioprine during breastfeeding, there is evidence of flow transfer, so it's safe if needed. Prednisone less than 20 milligram, again safe during pregnancy and lactation. And if a patient active postpartum and the patient taking more than 20 milligram prednisone, then we can delay the breastfeeding for more than 4 hours. Cyclosporin and tacrolimus, again, it's safe during pregnancy and lactation. Non-steroidal anti-inflammatory, it should be discontinued usually in the 3rd trimester because of patent ductus arteriosus. Anti-TNF, all anti-TNF is safe pre-conception and during pregnancy, but we have to stop infliximab, etanercept, adalimumab in the 3rd trimester, just for the safety of the baby, because they will to prevent the problem of tuberculosis post-vaccine. The only anti-TNF that is safe through the whole pregnancy is certolizumab, so it's safe during the whole pregnancy as well as lactation. Rituximab, if needed, it can be given in the 2nd, 3rd trimester for life-threatening situation, especially where we, with the vasculitis during pregnancy or severe lupus flare where we cannot give cyclophosphamide. So it's safe with lactation, and only with life-threatening disease during pregnancy we can give it. What about the other medication like anakinra? If needed, there is no strong data about it, like belimumab, abatacept, tocilizumab. We have, once patient get pregnant, we have to stop. During lactation, there is no enough data, but most likely there is minimal transfer in several studies. So some they indicate if needed, it's safe during breastfeeding. The medication that, which is contraindicated during pregnancy as well as lactation is the methotrexate, leflunomab, MMF, of course, cyclophosphamide and thalidomide. All this should be avoided during pregnancy and lactation. The JAK inhibitor, actually, there is no much data, so better to avoid it, though there is some few case report of safety during pregnancy, but better to avoid it because we don't have strong data yet. For men, again, the strongly recommended that can be continued if men planning to have kids, which is azathioprine, colchicine, hydroxychloroquine, and TNF. Conditionally recommended the anakinra, MMF, leflunomab, methotrexate. With methotrexate, there is a questionable, but in this guideline, they indicate it can be continued if it is a small dose, less than 15 milligram. Strongly recommended to discontinue is cyclophosphamide as well as thalidomide. So this about the medication issue. Just because of the time, I will try just to go quickly regarding lupus nephritis in with patients with rheumatic diseases. Lupus nephritis is risky. It increases the fetal loss and up to 36%, miscarriages as well as stillbirth. What we mean by remission, always we said a patient to get pregnant should be in remission regarding her lupus nephritis, or so the serum creatinine should be in the normal range. The glomerular filtration rate should be more than 60 ml per minute. No RBC cast, the protein urea less than 500 with normal serum creatinine and normal complement for at least 6 months. We mentioned that preeclampsia is one of common in patients with SLE, and especially for patients with history of nephritis as well as hypertension. So in patients with lupus, pregnancy is associated with increased risk of preeclampsia up to 32 versus healthy women. And the risk particularly increase if there is pre-existing hypertension, active lupus nephritis, or established chronic kidney disease, and the presence of antiphospholipid antibodies. And this you can, very important slide to differentiate between preeclampsia, lupus nephritis, as well as HELLP syndrome, because sometimes we are mixing them, and the treatment, of course, different for each one. In the preeclampsia, mainly they have more high blood pressure than the other syndrome. Preeclampsia usually after 20 weeks, rarely before 20 weeks. Thrombocytopenia is sometimes severe with the preeclampsia and can be there in the HELLP syndrome, but it is not the case in nephritis if there is no other activity of the lupus. The transaminitis, which is high liver enzyme, is seen 2 times in preeclampsia and with HELLP syndrome. With preeclampsia, they might have eclampsia, they might have headache, visual disturbance, pulmonary edema, and they might go into eclampsia itself. The other important differential diagnosis between the lupus nephritis and preeclampsia, the uric acid usually elevated in preeclampsia and normal in lupus nephritis, and the creatinine usually normal to mild elevation in preeclampsia. So how to manage these patients with risk factor? There is an advice to start antiplatelet for patients with risk for preeclampsia. And this low dose aspirin showed reduction in the risk of preeclampsia of 20%. I think there is no time isn't it, Dr. Khalid? There is no time. We have to. I can continue.
Yes, yes.
Okay.
So,
okay. Let us take a case because rather than talk. Here, a 39 years old woman with SLE on azathioprine hydroxychloroquine. She got persistent positive lupus anticoagulant and high titer of immunoglobulin anti-cardiolipin antibodies. She got history of intrauterine fetal death at 18 weeks, which is attributed to antiphospholipid syndrome. There was no thrombosis. Her anti-SSB, which is antibodies, are negative. So in such a scenario, with a patient who are stable lupus but positive antiphospholipid syndrome, what to do in such a patient and how to manage her for good outcome and pregnancy. So persistent high titer of IgG or IgM anticardiolipin antibodies and positive lupus anticoagulant, all of these risky for pregnancy loss, as I mentioned, as well as preeclampsia and early delivery. So what to do, or how frequent to have an antiphospholipid in patient with systemic lupus erythematosus? I don't know why the slide is not moving. Maybe I'll try from here.
You can stop share and share again. Yes, yes.
That's okay.
Yes.
Okay, for such a patient, because she's having definite antiphospholipid syndrome, we have to give her with previous pregnancy loss. So we have to treat her with a dose which is not a prophylactic dose. We have to treat with therapeutic dose of heparin and here, this slide just to show you that we have to screen for antiphospholipid antibodies. Antiphospholipid antibodies in patients with SLE reaching in some cohort up to 40%, but the clinical syndrome in up to 15%. So pregnant woman with antiphospholipid syndrome with history of thrombosis, we have to replace warfarin if she is already on warfarin to heparin like 6 weeks before conception and continue heparin throughout gestation. Low molecular weight heparin in the therapeutic dose should be given during pregnancy. And sometimes if patient on this regimen and got still abortion, it's safe to add low dose aspirin in such a patient. So in all patients with SLE and positive anticardiolipin and beta-2 or any one of the antiphospholipid antibodies, secondary antiphospholipid syndrome should be prevented with low dose aspirin if there is no definite syndrome. So if there's time for neonatal lupus, or I can stop here. I will go to summary. Continue.
Yes.
Okay, So this is a case, a young woman with rheumatoid arthritis with very mild disease, controlled on hydroxychloroquine for 1 year. She got positive anti-SSA and anti-SSB antibodies with negative antiphospholipid. So what is the risk of having neonatal lupus and heart block in such a scenario? So what is neonatal lupus? Neonatal lupus and the presence of or absence of complete heart block is related to the presence of the anti-Rho antibodies, regardless whether a patient have Sjögren or not. So just the presence of the antibodies can carry the risk of having neonatal lupus. Moderate to high titer is associated with complete heart block, but it's low percentage. Like if there is no previous heart block, is only in 2%. The risk of neonatal lupus with usual manifestation, which is rash, it can occur in up to 20%, which is the common, just mild rash, which improve within 6 months. So just here, the most severe complication of these antibodies is the congenital heart block, and we have to avoid it. The incidence, as I mentioned, if there is no previous congenital heart block, it's 3%. But if there is previous history of neonatal lupus, this percentage of complete heart block can increase up to 18%. The other form of neonatal lupus, they might have immune thrombocytopenia, autoimmune hemolytic anemia, or cholestatic hepatitis. So we have to be careful for the fetus, and we have to inform the pediatrician regarding this issue, and that the mother have positive antibodies, and we have to search for such a things. How to monitor this patient? If it is positive, we have to do maternal fetal monitoring, especially between 16 and 26, mainly with the ultrasound of the fetus, and you have to do it like every other week until 34 weeks to detect early change, because we have to manage early. And in such a patient with positive Rho antibodies, we have to start the hydroxychloroquine for these patients, because it was found that it is safe and it reduces the incidence of neonatal lupus and even complete heart block. And how to manage if we find first or second degree heart block at 16 weeks or at any week after 16 weeks, then to prevent third block, we can start 4 milligram dexamethasone, and we do serial echo just to be sure that there is reverse of this block. If the third degree, it's controversial whether to start or not, because sometimes it's associated with myocarditis, and if it is detected late, I mean later than 2 weeks, and it's persistent heart block, usually the management of dexamethasone is not, there is no much of control study that indicate the efficacy of dexamethasone in a patient with complete heart block. Just observe and cesarean delivery usually, and the only management is pacemaker for such a patient. Sometimes in persistent second block with dexamethasone, we might give IV immunoglobulin to reverse or to prevent third degree block. So in a summary of my talk, the rheumatic disease should ideally be well controlled for several months, at least 3 to 6 months, on a safe pregnancy medication. Most women with inactive and stable rheumatic disease, autoimmune disease, pregnancy is safe for mother and fetus. And the main risk factors for adverse pregnancy course is active disease, nephritis with proteinuria, hypertension, as well as maternal serum antibodies of SSA, anti-Rho, anti-La, positive antiphospholipid antibodies. Hydroxychloroquine is safe and shouldn't be stopped in pregnancy. We have to check for any patient with autoimmune disease, the SSA, SSB antibodies, as well as antiphospholipid antibodies before or early in pregnancy. we have to check for antiphospholipid prior to giving any contraceptive based hormonal therapy. For SLE patient, because most of the adverse event in SLE patient with antiphospholipid or without antiphospholipid, we have to educate them about the treatment and the safety and the importance to have an inactive disease prior to pregnancy and to review their medication in every visit. And we discuss with the patient because these patients, they are young and they want to conceive. So sometimes they come just appear for us, despite of all of this counseling, they come to us pregnant. So always stress on them, and thank you for your listening.
Thank you so much, Dr. Hanan, for this nice wide spectrum lecture covering all aspects of pregnancy with rheumatic disease. We have an example for a case scenario. If a patient with active SLE with lupus nephritis, you on a teratogenic drug, MMF, and she got pregnant, accidental pregnancy, what to recommend?
Because we have to inform them that they will have congenital anomaly because they are on MMF. And if they are early in pregnancy, it's safe, to induce abortion because the percentage is high. So we have to talk with them about the risk, and there is high risk. And if they want to continue, but they should know that they have the risk of the congenital anomalies. And if they want to continue, of course, you have to stop the MMF to shift them in safe medication like Imuran and prednisone to control the disease and observe. But also, usually in patient like this scenario, we induce abortion for them.
Because it is a real danger on the mother and the fetus as well.
Yeah, especially if it is in the first trimester. But if they come late, they can't continue because it's not safe for her even after 3 months. Usually they did an ultrasound, observe the baby for any anomaly and so on.
Yes. There is an inquiry about Bilista in pregnancy. Is it safe or?
Yeah, as you can see from the ACR guideline, it's mentioned it's better to stop it if patient gets pregnant. There is no enough data to say it's safe. The only thing is just to stop it. But during lactation, if the patient needs it, they can take it.
Nice. There is a last question about do we still have a real risk of PDA, patent ductus arteriosus, with non-steroidals and aspirin in the last trimester? Do you recommend to discontinue or continue? Yeah,
all data, and in this data showed there is a delay in the closure of patent ductus arteriosus. So better to avoid it. Usually, if there is pain, we can control it with non-steroidal, small dose of steroid. And the other issue about non-steroidal anti-inflammatory, even early in pregnancy, sometimes it prevents implantation of the fetus and delay pregnancy. So usually, I don't advise it for any SLE patient because of these two reasons, as well as because of the renal problem. And if they need it for other disease like for SPA or RA, if they are not controlled, we inform them about the risk of everything. And in the third trimester, definitely you have to stop it.
But regarding aspirin?
Aspirin, of course, safe and is recommended to be given in a patient with antiphospholipid antibodies without syndrome. And in some situations where they are patient risky for preeclampsia, so we can give it. And it's safe. Sometimes they advise during labor, just within 1 week of labor to hold it to avoid bleeding. But it's not, the bleeding with that is not that much. Usually we continue with aspirin without harm.
Yes, it's an important medicine. Nice. Thank you so much, Dr. Hanan, for your nice presentation. As usual, jazakumullah khairan. Inshallah, we hope to meet in the near future in a face-to-face conference.
Inshallah. Thanks a lot for all of you. Thank you.
Now we'll shift to the sixth presentation in our symposium with our dear Professor Dr. Jamal Atiyah. He is the consultant and head of rheumatology department in Saudi General Hospital Asir. He is the professor of rheumatology, faculty of medicine at Azhar University. Welcome, Dr. Jamal. Jamal will talk to us about a hard topic today about the understanding the immune system.
السلام عليكم دكتور خالد.
السلام
السلام عليكم.
السلام ورحمة الله وبركاته. Welcome.
First of all, I would like to thank Dr. Khalid and Mr. Tamer for continuing this activity. Extend my thanks to Professor Dr. Hanan for their very complicated topic. Actually, we see this problem daily in daily practice in my clinic. The patient he get pregnancy, and sometimes he ask me, I'm get pregnant, so we take medication. And a big dilemma. Actually, she cover all question we can face with the patient. Thanks to Dr. Hanan, and again, I will go to my topic. Actually, my topic a little bit go to the basics of immunology. Actually, if we know the basic of immunology, we can go to understand what happened in rheumatic disease. My agenda, we go deep in some basic immunology to detect what happened inside this immune system and autoantibody, how can be released in this system, as well as antigen-antibody reaction. And at the end, I will give brief about the role of immune system in some rheumatic disease. Immune system have organs, cells, and molecules. Actually, the target of all pharmaceutical companies now to this molecule, cytokine, interleukin, and interferon. The immune system have two arms, innate immunity, acquired immunity, human by human response and cellular response. Both arms is together by innate immune system, macrophage, dendritic, and system is highly specific. And our immune system has three different cells remember the previous attack and pathogen. As we know, the antibody is Y-shaped, can be interact or introduced in the body after infect your body by antigen. The pathogen, this release antigen causing a disease. The antibody or immunoglobulin can be interact with antigen in different way. The function of antibody, the main function of opsonization, promotion of phagocytosis by antigen, by macrophage and the neutrophil. Element activation by IgM, IgG, antibody as the antigen to antibody antigens. Cell mediator antigen. A T cell do not possess these receptors. A T cell need to have antigen presented to them. The antigen presented to cell by antigen presenting cells. The antigen presenting cell, we have the general, actually all cell professional antigen presenting cell is only B cell, macrophage, and dendritic cell. Using major host compatibility class 1 and professional using general interact with CD8 T cell and professional interact with CD4 T cells. In this diagram, I will mention how can antigen-presenting cell present this antigen to immune system and how can immune system interact to release antibody. The general antigen-presenting cell take the biproteases enzyme, can be protect this protease enzyme to small part or small peptide. This small peptide presenting to class 1 major host compatibility. This presentation end by present to cell membrane. Once this peptide presented to cell membrane will be interact with T cell receptors. This interaction activates T cell to release lot of cytokine. In cell-presenting antigen, before cell-presenting antigen will be die, and this is one of function of immune system to eliminate cell-presenting antigen.
Dr. Red Chest.
The professional antigen-presenting cell have ability to take up extracellular protein, break down this protein into peptide, attack it to major host compatibility class 2, and present this peptide CD4 to T helper 1 and T helper 2. In another way, the professional antigen presenting cell takes the protein from outside the cell, from the blood, especially by macrophage cells, takes this protein and process to small part. This small part after deviated or after deviated to small part is presenting to the cell membrane by major host compatibility class 2. After presentation to cell membrane, interact with T helper 1. This interaction activates T helper 1 to release lot of cytokine, especially IL-2, interferon gamma, and tumor necrosing factor. This cytokine is returned back to the CLP4 presenting this antigen to eliminate our body from this one. Another way to professional antigen presenting cell, the B cells have a special receptor to this antibody, to this antigen, and take this antigen inside the cell to process into small part. This process end by presenting this process to the cell membrane. Once present to cell membrane, interact with T helper 2, not T helper 1. This interaction activate T helper to release IL-5, IL-6, 10, and IL-4. This cytokine return back to the cell presenting antigen to interact with this one. This B cell it changed to another stage. Plasma cell will release is presented before. From previous this slide, our immune system can attack it himself. But actually we have two concepts, central and peripheral tolerance can protect our immune system from attacking himself. The tolerance, this immunoglobulin unresponsive to self-referred to tolerance or self-tolerance, inherited property of immune system. It is very important to human health. A response against foreign antigen without attacking the host. A specific lymphocyte plus antigen activate a lymphocyte. This activation responded by or tolerated by elimination of this antigen. This influence or the tolerance is influenced by genetic factors, route of exposure to the antigen, the dose of antigen, time of exposure, structure of allergen and antigen, co-exposure with extensor infections. Also, this tolerance is immune system regulated length and the size of this response. Cell with receptor for self-antigen are destroyed in thymus and bone marrow. self-reacting lymphocytes are made up to become non-responsive. This is the peripheral tolerance. And if not balanced, this leading to autoimmune. So our immune system have a central and peripheral tolerance. If we have a balance, actually not get any disease. But if imbalance in central or peripheral tolerance, will get autoimmune disease. The autoimmune, it is the failure of immune system tolerance or immune reaction against autologous antigen. So the autoimmunity, that's mean combination of genetic susceptibility, environmental factor, as well as immune regulation by cytokines. What's a cytokine? It is a polypeptide reduced by cell of immune system in response to antigen. Cytokine act by binding to specific receptor on target cells. A response to cytokine consists of gene activation, new function, and proliferation of target cells. Cytokine regulate immune response in many ways: autocrine, paracrine, and endocrines. It is based on cellular resource: monokine, lymphokine, interleukin. Monokine is monocular phagocytes. Lymphokine is produced by lymphocytes, and interleukin produced by leukocyte IL-1 and IL-2. Subfamily of cytokine primary function in direction for migration of cell. This is called chemotactic or chemokines. Actually, we have a 5 major family receptor for the cytokine: immunoglobulin receptor family, hematobulin receptor family, necrosing factor, and chemokine. Here, the mode of action of cytokine. Also, the cytokine can be or can act to activate by endocrine actions, so secrete another site. The cytokine, sorry, during inflammation, macrophage and the dendritic cell make pro-inflammatory cytokines like TNF alpha and interleukin 1, which is assigned to endothelial cell to make dilated blood vessels, as well as leaking of the fluid, influx of the plasma outside, and sticky of influx of neutrophils first, then monocyte and lymphocytes. Chemokine induce movement of leukocyte toward the chemical gradient of cytokines. After we know the cytokine and their interaction with their receptor, actually the cytokine interact with their specific receptor in cell membrane. This interaction ends by inflammation or joint problems or sign of the interaction between cytokine and their receptor. So from this diagram, the target of pharmaceutical company to do or to block the interaction between the cytokine and their receptors. This blocker by many ways: first by neutralization by monoclonal antibody. So we can inhibit the interaction between cytokine and their receptor to stop the inflammation. Also, we can interaction by neutralization and B block this interaction there after the neutralization of these cellular receptors. Receptor blocker by monoclonal antibody. This one also can block this interaction between the cytokine and their receptors. So not get any inflammation by receptor blocker by monoclonal antibody. Also, we can block this interaction by receptor blockade by receptor antagonist. So the end result, no inflammation after this blocker. So the cytokine, we have many types: interferon, interleukin, and tumor necrosis factors. The interferon is signaling protein produced by virus-infected monoclonal or monocyte lymphocytes, and interferon with the virus replication, interfere with the virus replication. أنا عندي محاضرة بس اديني 5 دقايق، طيب أنا قدامي ربع ساعة أخلص المحاضرة، طب هعمل إيه؟ أنا قايل للناس كلها إن أنا عندي محاضرة دلوقتي. ادي ربع ساعة إن شاء الله هكون خلصت. سوري دكتور خالد، آسف سوري. The interferon is working by newborn cells that virus is around. If we did not have interferon, most of us maybe die from influenza. The role of interferon to activate newborn cells. This activation activates the newborn cell to become ready to viral infection by interferon. Immune system and the COVID-19. Angiotensin converting enzyme 2 act as a receptor for COVID-19. ACE2 present in epithelial cell of many cell types. Exchange of oxygen and the carbon dioxide occur in epithelial lining. ACE2 cannot break down angiotensin 2 protein. Angiotensin 2 drive lung injury, inflammation, and tissue damage. As we see here in this diagram, the angiotensin converting enzyme is break or speak to the viruses. This break will stop the action of angiotensin converting enzyme. This leads to block or lot of angiotensin converting enzyme inside the blood. Temporarily suppressing immune system during the early stage of COVID-19, the innate immune response start after the infection, killing the viruses. The innate immune response relies heavily in interferon type 1. Adaptive immune response kick in days later if any virus is remained. In first cytokine released during COVID-19, IL-1 and tumor necrosis factor, which attract white blood cells and nuclear factors to interfere at the site of the infection. This cell attacks the pathogen as well as release additional cytokine, especially interleukin 6. IL-6 is essential for adaptive immune response. Overreaction of immune system leading to irreversible tissue damage called cytokine storm syndrome, and this one kill the person, or this is the main cause of kill of the patient with COVID-19. T lymphocyte is rapidly activated to become pathogenic T helper. A T helper induce monocyte highly expressed IL-6. IL-6 stimulates another cytokine, special IL-1, tumor necrosis, interferon gamma, and C-reactive protein. Actually, this is very high in patients with activation or with activity of COVID-19. IL-6 increase the vascular permeability, resulting in microthrombosis, leading to ischemia and tissue death. And most patients with COVID-19 is died from microthrombosis. The theory of autoimmune disease, how can our immune system end by the sequence of end by autoimmune disease, leading to appear of the disease in our patient? First, release of normal sequestrated antigen. Antigen is appear in the patient not know before. Increased expression of autoantigen. Molecular mimicry like epitope spreading, defect in apoptosis, decrease in suppressor and regulatory cells, and alteration in T helper 1 and T2 cytokine pattern, increase expression of co-stimulator molecules, release inflammatory mediators. Also, the inflammation during immune system is a complex biological process associated with pain and swelling of the tissue. The key player in innate immune response. Chronic inflammation equal tissue damage. Chronic inflammation activate the macrophage to injury of the tissue. Macrophage release toxin reactive oxygen species. Chronic inflammation is almost accompanied by the tissue destruction. In systemic lupus, the immune dysregulation leading to autoreactive and autoantibody. Immune complex mediate damage to glomerulonephritis. Direct autoantibody induced damage to thrombocytopenia and hemolytic anemia. Antiphospholipid syndrome induced thrombosis and pregnancy morbidity. Complement mediate inflammation affect the CNS and during hypoxemia. During the pathogenesis of systemic lupus, in innate susceptibility plus environmental stimuli, both leading to autoimmune proliferation with hyperactivity of T and B cells, impaired tolerance, defect in immune complex clearance, this leading to load of or pooling of the body of the patient with systemic lupus with lot of autoantibody. This ended by apoptosis, self-recognition, self-exposure, and foreign antibody cross-reaction. This will lead to tissue damage. This is a diagram of, in brief, about the pathogenesis during the patient of systemic lupus. In rheumatoid, the T cell is mediated or the target of the pathogenesis. Most wide accepted hypothesis, professional antigen presenting cell encounter some unknown antigen. If present, this antigen interact with CD4 T helper. In genetical predisposed individual, the start by immune chain reaction. In the disease process, the imbalance between pro and anti-inflammatory cytokines. As we see here, pro-inflammatory against anti-inflammatory cytokines. The pro-inflammatory predominate, overwhelming the nature of regular inflammation. So the end imbalance between cytokine in toward of chronic inflammation, and this is what happened in patient with rheumatoid arthritis. This diagram summarizes what my colleague, Dr. Amir, said, how can pathogenesis in rheumatoid end by degeneration of cartilage, antigen presenting cell, whatever plasma cell, dendritic or macrophage, interact with T cell receptors. This interaction leading to release lot of cytokine. This interaction leading to activation B cells, activation B cells leading to production another cytokine, especially IL-6 and tumor necrosis factor. This activity aimed by stimulation B cells to become plasma cells. The plasma cell will secreting rheumatoid factor, anti-CCP plus immune complex complement. In this diagram also, after activation of T cells will be activate macrophage. Also macrophage add another cytokine, IL-1 and tumor necrosis factor. As we see here in this whole dilemma, the patient with rheumatoid have a lot of cytokine inside the blood. This cytokine act with chondrocyte. This activation act in production of collagenase will be act in cartilage to do tumor necrosis factor, will to do ballness formation, the bone. This diagram summarizes what happened in the patient with rheumatoid and how at the end can they get bone erosion and the deformity of the joint of patient with rheumatoid. In psoriasis, T cell generate pro-inflammatory cytokines. In skin, pro-inflammatory cytokine, tumor necrosis factor, act in keratinocyte, lead to proliferation and this proliferation is prolonged survival, leading to skin thickening and plaque formation. Cutaneous lymphocyte associated antigen is expressed in lymphocyte homing to the skin lesion. At the trigger or environmental triggering factor in skin with patient with psoriasis, the keratinocyte will be released cytokine, tumor necrosing, IL-13, transform growth factor beta to act on dendritic cell. This interaction will be stimulate dendritic cell to release IL-23. IL-23 will act in T helper 17 to release IL-17 tumor necrosing factor. This will be returned back to act in keratinocyte to release pro-cytokine, another epidermal remodeling, and lead to formation of psoriatic plaque. We have another enzyme, what's called the phosphodiesterase enzyme, responsible for hydrolysis of cyclic adenosine monophosphate that control network of pro-inflammatory and anti-inflammatory mediator. The balance between cyclic AMP and AMP within the cell may modulate expression of pro-inflammatory and anti-inflammatory mediators. In this diagram, as we see here, phosphodiesterase enzyme act on cyclic AMP to activate to AMP. Pooling of the cells with AMP will produce pro-inflammatory mediator, closing factor, alpha, IL-23, IL-17. Sorry, Dr. Khalid, sorry. So the phosphodiesterase is pooling the cell by adenosine monophosphate. This will lead to pro-inflammatory mediator, special tumor necrosis factor alpha, IL-23, IL-17. At the same time, phosphodiesterase reducing anti-inflammatory mediator, especially IL-10, but unfortunately, anti-inflammatory cannot be overcome the pro-inflammatory mediator by phosphodiesterase enzyme. We go to the JAK. The JAK is the intracellular enzyme involved in stimulating immune function, regulation of gene expression in response to cytokine. JAK activate enzyme transducer and activator of transcription, what's called STAT. STAT dissociated and migrate to the nucleus. STAT dimer binding to DNA and activate target genes. In this diagram, as we see here, after activation of the receptor of JAK, we get the STAT formation. STAT will be shuttled from cytoplasm to inside the nucleus. This shuttle to activate a specific gene to release load of cytokines. So the STAT, when activated, will lead to cell proliferation, cell activation, survival, localization, differentiation, and cell migration. All this will lead to cell or event lead to this disease manifestation. And go to osteoarthritis. Actually, we look for osteoarthritis in the past as consecutive tear and wear, degeneration disease, cartilage disease. But now we look for osteoarthritis as a cell-derived mechanism, pro-inflammatory disease, multiple disease, multiple tissue disease, and the biological challenge will be open the window to intervention to treat the patient with osteoarthritis. Our cartilage can help us to protect the cartilage or can be repaired. The cartilage can be repaired by stimulating synthesis of collagen and proteoglycan, increase IL-1 receptor antagonist, increase tissue inhibitory metalloproteinase expression. So the degradation in osteoarthritis outstrip repair of it's the target point of patient with osteoarthritis 1 and tumor necrosing factor or early osteoarthritis will act in 2 points. This cytokine will act in synovial cell as well as in chondrocyte. This action will lead to matrix metalloproteinase synthesis, stenoid synthesis, and chondrocyte apoptosis. Chondrocyte apoptosis decrease the lifespan of chondrocyte and enhancing the osteoarthritis or degeneration of joint. At the same time, matrix metalloproteinase is interact to produce collagenase, stromolysin, and gelatinolysis. At the same time, anti-metalloproteinase also will be act in patients with OA to release tissue inhibitory metalloproteinase 1 and 2 to produce alpha-2 macroglobulin. As we see here, the balance between matrix metalloproteinase and anti-matrix metalloproteinase, at this time, the joint is still in healthy state. But unfortunately, the matrix metalloproteinase will be or overstrip the anti-metalloproteinase, and so the new therapy metalloproteinase action as well as the matrix metalloproteinase is the forefront from speaking to by gap junction in matrix metalloproteinase production. Acute attack, for especially acute attack of gout patient, we have what is called apolipoprotein. This is very important role in pathogenesis of hyperuricemia and have cluster type of apolipoprotein. The gout patient have high mutation of genotype of apolipoproteins. Urate crystal is coated by apolipoprotein. This coating prevents inflammatory response. In this diagram, the urate crystal, the urate crystal can look for this crystal as a normal. If any reason this crystal, our immune system we look for this crystal as a foreign protein or foreign material. This coated by immunoglobulin. Once it's coated by immunoglobulin, is present this urate crystal to antigen presenting cell. This presentation will be activated T cell and end by macrophage stimulation to release IL-1/6 and tumor necrosis factor. At the end, we'll get acute attack of gouty arthritis. Finally, the immune system is made up two different components. Both systems are necessary to efficient and protection against pathogen. Proper regulation of this process is important to health of the host. Thank you, Dr. Khaled.
Thank you so much, Dr. Gamal, for the nice presentation as usual. Dr. Gamal, you are with us?
Director, call me anytime. Okay, Dr. Khaled.
Yeah, thank you so much for the nice presentation. Jazakumullah khairan. A very difficult topic. You hear me? Yes, the voice is not clear.
Okay.
Thank you so much. I have a question about regarding the innate immunity.
تفضل دكتور خالد.
We have a bit, inquiry about innate immunity. Do we have any medication that can interfere with the innate immunity?
Actually, so difficult because you know the immune system until now, the main action of a pharmaceutical company, it depends mainly on cytokines. But if we go deep to the innate immunity, so difficult because it depends mainly on T cells. It cannot deplete the T cells in the body. Even the medication in marketing now, it can be depleted B cells, but T cells, no medication can be depleted T cells.
Difficult.
Yeah.
Thank you. جزاكم الله خيرا في الجماعة. Very nice presentation.
بس خد الإبرة دي في الطوارئ دلوقتي.
Inshallah, we'll keep with us. Keep with us all. We'll restart again within 10 minutes. Inshallah. We'll give a option for praying. Inshallah, we'll meet after 10 minutes. Inshallah. Keep in mind, please. Thank you.
ما انت معاك الوصفه، انا مدي لك الوصفه ساعه لايف.
دول الحاجات دي، يعني دول الحاجات دي مش هاويهم او الفوليك اسيد. هو دفعه الفوليك اسيد برضه بتلاقي لحظه 5 مللي. عارف واحده منها فيها شيء لا عشان معاكم طيب
السلام عليكم ورحمة الله وبركاته. Welcome back again. Inshallah, we'll have my dear professor, Dr. Omar Al-Gabi. Dr. Omar is a consultant rheumatologist in the Robert Jones and Agnes Hunt Orthopedic Hospital Trust. Dr. Omar, I need to welcome you. We are very proud and happy with your share in our next second share for you in our SGH symposium. A very nice topic with the renal manifestations in antiphospholipid syndrome. I think antiphospholipid is your subspecialty.
Yeah, I think so.
Welcome, Dr. Omar.
I'm just trying to share the file, the file as the. All right.
Okay. You can go to the bar and
Yes.
share screen. Yes.
Okay. Just a second. You got them?
Yes, yes.
All right. Okay. That's great.
Nice.
تمام كده؟
تمام.
طيب. السلام عليكم اخواني وحبايبي واصدقائي الروماتولوجيست. انا سعيد جدا 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 ان انا اكون وسطيكم النهارده، خصوصا الكوكبه اللي موجوده. واشكر الدكتور خالد والاستاذ تامر لدعوتي للمشاركه المره دي، واسال الله ان شاء الله المره الجايه تبقى فيس تو فيس، لان انا من الناس العواجيز اللي بكره التكنولوجي دي. Too much technology is not good for the health.
لسه شباب.
الله يكرمك. I'm proud of that. النهارده هتكلم على can the little wolf damage the kidney? You know that rheumatoid arthritis, systemic lupus erythematosus is the wolf, and we know renal lupus is very common. Not very common, is a common manifestation or dangerous manifestation of lupus. But the question today is whether the little wolf, which the name I name it myself to the antiphospholipid syndrome, can it affect the kidney as well or not? Can the little mimic the major? This is the question. I'm working here in this hospital and covering with 6 of my consultants this red area. For the people who don't know me, I'm basically a sincere Egyptian. I had all my qualifications in Egypt, and I got some from the UK. And to describe myself, I'm working here and living in my country, or in my countries, because Saudi Arabia is a second country for me. Our core value is patient first and be positive. Some of the past that lupus has been noticed in the 13th century, and the first one wrote about it in 1872. And in early 19th and in the 1950s, the false positive test for syphilis has been reported. After that, the disease will established in 1963 to 72 after discovering the lupus anticoagulant. Antiphospholipid syndrome, named by the wolf, and the antiphospholipid lupus named by the wolf, and the antiphospholipid syndrome, it is a little wolf. And in the picture with me is Professor Hughes, and who wrote a lot of, he's a pioneer of antiphospholipid syndrome, and I'm very proud to be with him, and I know him very well. And the little wolf also is a name for Latin Americans. In 2000, they discovered that there is evidence of vasculitis in system in antiphospholipid syndrome. Most of the rheumatologists think that it's vasculopathy, but the real thing is there is evidence, strong evidence that it is vasculitis. So it is a syndrome called anticoagulable syndrome or Hughes syndrome. It is an autoimmune disease defined by the presence of arterial or venous thrombosis with events of pregnancy morbidity on a patient who tested positive for antiphospholipid syndrome phospholipids. It can be a primary disease or secondary to other autoimmune diseases like lupus, Sjogren's syndrome, rheumatoid arthritis. And lately, after COVID, we found that there is a lot of patient has been shown to have antiphospholipid syndrome, as if the virus infection, the pandemic, triggered the hidden underlying subtle manifestation of the disease. So if you have the gene and you are more prone to have the disease, one of the external factors like smoking, pollution, stress, infection as well can cause that, especially viral. This picture, I don't want to go through this picture because this is controversial, but this is the most common classic form of how blood clots get in antiphospholipid syndrome. Basically, it affects kinase complex, prothrombinase complex, and the protein C complex. I'm delighted that this lecture has been recorded, so anyone is welcome to have it and to read it in fine details, because I'm going to rush now to get to the point. Antiphospholipid antibodies may affect all the pathway, indicating with the asterisks we said that. And this is a little bit complicated slides for intracellular changes in antiphospholipid syndrome. And this will highlight that antiphospholipid syndrome is a type of vasculitis diseases. Mechanism of thrombosis, it is affect the platelet circulating factor and the endothelium itself. So that's why it is there is an element of vasculopathy and now evidence of vasculitis. And I will come to this one when we talk about medications. The clinical picture of antiphospholipid syndrome, it can cause any type of arterial or venous thrombosis. Neurological manifestation is very common, and we need to consider that in certain type of patient. I'm going to tell you about what type of patient you can think about. Obstetric, cardiovascular, gastroenterology, hematology, dermatology, and here we are going to talk about renal manifestation today. It can affect the orthopedic and the osteolytic necrosis of some blood vessels of Leonate. It can affect the lung, and it can be as nasty as causing catastrophic lupus, catastrophic antiphospholipid syndrome. Rare manifestation, it can affect the ear itself. Intermittent peripheral neuritis, I've seen in my entire life one case, and the empty cell tertiary syndrome. So it is a wide disease. This is the clinical picture of typical clinical picture, either common or less common. And the diagnosis, there is two things here I would like to emphasize, that the diagnosis clinically and the laboratory. And it is mainly clinically because the laboratory is deceiving sometimes. So we have certain patients who has been diagnosed as having seronegative antiphospholipid syndrome, but seropositive when we found lupus anticoagulant, anticardiolambin antibody, or beta-2-GB1, glycoprotein 1 is positive, or any one of them is positive. And for classification for researchers, we need to repeat this lab 3 months after and to have 2 positive blood tests. But in reality, the situation is totally different. Seronegative, described by Professor Hughes, and this is the criteria. I can go back to them. Seronegative antiphospholipid syndrome, and this one of my patients, seronegative antiphospholipid syndrome, came with her permission. I got her picture. She is quite happy to share this picture. This is my patient, and they shared the management between Professor Hughes and myself when I was in Helsing in 2001, 2006. She came in with this picture, and we did everything, because the most common is common first. So we get a delayed diagnosis. After diagnosing her as seronegative antiphospholipid syndrome, started her on aspirin. This was the case after a spontaneous amputation of the index finger. Laboratory criteria, it's not something we are not interested to go ahead for that today. The prognosis can be either just some of the from very mild, not requiring even aspirin, to very aggressive to catastrophic or CAPS. 6% who survived remain symptoms free. This is regarding to CAPS. 20% to develop another related events, and it can be a real killer disease. The future, as I said, that it is not only vasculopathy, but it is vasculitis in 2008. And they also, Professor Hughes put some treat to target index to show the global antiphospholipid syndrome score. And by this score, you can see an objective progress to the patient progress. And this is how to calculate the score. Back to the topic today. This is to remind you about the kidneys and the anatomy. This is the inferior vena cava, renal vein, the renal arteries. And when we go a little bit in, we can see the renal arteries giving 3 main branches, and each branch is given another branches. And when we go a little bit in, there's a lobar branches. Some more in, we have these glomerular capillaries of the glomeruli, and we know that the capillary got its blood from the afferent, and the rest go from the efferent. All blood vessels from the inferior vena cava till afferent and efferent can be affected by antiphospholipid syndrome. And here a slide showing that the renal arteries, internal arteries, glomerular capillaries, renal veins can affect the antiphospholipid, can be affected by the or involved by antiphospholipid syndrome. The major kidney is a major target organ in antiphospholipid syndrome. Renal thrombosis can occur at any level, as we said, and the histological finding can be either ischemic glomeruli, thrombotic lesion without glomerular or arterial immune deposits on immunofluorescence. In patient with lupus nephritis, antiphospholipid syndrome can have an adverse effect on the prognosis and the prognosis can be very poor. So if you have an antiphospholipid syndrome in the primary cases, and you got a renal affection, the prognosis will be poor. That's why we need to be vigilant to have an early diagnosis of this disease. What I'm doing in my practice is that for each patient come to my clinic, whether with antiphospholipid syndrome, or lupus with secondary antiphospholipid syndrome, I measure the blood pressure, comparing it with the previous one, and at the same time, I go for urine dipstick to see whether there is any protein or not. If I got any protein, I will take the condition further. Histology is very important. Renal thrombosis can occur at any level. As we said, this is the same picture, the same slide. Oh, this is a repeated one. It can cause nephropathy as well through incidence of renal involvement in primary antiphospholipid syndrome has not been well determined, in a part because of the frequent occurrence of thrombocytopenia and the systemic hypertension, and the renal biopsy is very important for diagnosis. Patients with antiphospholipid syndrome may have a higher risk of developing biopsy-related complication. So if you, the people who are going to take the biopsy, get very worried because of the hemorrhage, which can happen, or because of the biopsy can trigger thromboembolic manifestation itself. So it could be quite challenging. So early sharing these cases with nephrologists is mandatory. If I missed anything, anything in this presentation, I don't want to miss that to involve a renal physician, nephrologist as early as you can. This is a picture here taken from a nephrologist slides showing interloper artery, showing fibroelastic initial thickening with almost complete obliteration of the lumen. So if you go to this one, there is a lumen here, there is a lumen here, but this one is almost gone. The thrombotic pathway, we don't have to worry about that, but I would like to highlight the vessel wall abnormalities and the endothelial injury. And this is will show you it is not only a blood clot formation, but also a disease affecting the blood vessel itself. And this is have a direct implication on the management. Systemic hypertension and antiphospholipid syndrome is one of the major issues, and it's describing an association with liver reticularis and the antiphospholipid syndrome, antiphospholipid antibodies. So in practice, if you got a patient who has liver reticularis and the high blood pressure, think about antiphospholipid syndrome. Send the patient to have the antibodies, and take it from there. In one of the studies, hypertension was present in 90% of their 16 patients. Was sometimes the only clinical signs. So this is very important. So again, blood pressure is very important. Renal artery stenosis, because of antiphospholipid syndrome, not because any other things, can cause hypertension and also thrombosis. So the antiphospholipid syndrome can cause both. Here we are, a patient who has a liver reticularis and the hypertension, do a lupus anticoagulant, and they look for lupus nephropathy or antiphospholipid syndrome nephropathy. Renal artery stenosis, I said about it. It is very important to control the blood pressure to avoid end-stage renal failure. And the major part of controlling the hypertension is to treat the antiphospholipid syndrome. That's why in a patient who has hypertension, young age, and they will come to the criteria for the patient, they might get antiphospholipid syndrome. In this certain cohort of patients with high blood pressure, usually they need about 3 or 4 antihypertensive to treat. But if you are aware and minded with the disease, you can treat it, and you might end up by having normal blood pressure, or just one medication will be more than enough. And this is a picture of renal artery stenosis because of the antiphospholipid syndrome. And the nephrologists are very clever to differentiate between whether this renal artery stenosis is because of antiphospholipid syndrome or because atherosclerosis. Yeah, this is the rash. Renal infarction is another manifestation of antiphospholipid syndrome. As I said, that the blood clots can affect interparenchymal vessels, and this ends up by shrinking kidney. So it is either by in-cycle thrombosis or emboli from the pre-existing upstream arterial lesion or a cardiac vascular lesion. Clinically, the patient with renal infarction, which could be the first manifestation of antiphospholipid syndrome, may present. They come to the physician with flank pain, يقول لك جنابي منفخة، جنابي بتوجعني، جنابي مش عارف إيه. So don't forget جنابي. Flank pain, severe hypertension, and or renal dysfunction. This triad is highly suggestive of renal involvement in antiphospholipid syndrome, whether primary or secondary. Histologically, the glomerular ischemia, tubular atrophy, interstitial fibrosis may be seen with renal infarction due to primary. Although renal infarction is a rare complication of antiphospholipid syndrome, this diagnosis should be considered in any young patient who presented with renal infarction. So if you have a young patient with renal infarction diagnosed by a biopsy, and this will come to you from the nephrologist and not other way around. The nephrologist will do a biopsy, get renal infarction in a young patient. So they should be aware that it could be antiphospholipid syndrome, and they refer it to yourself as a rheumatologist. So antiphospholipid syndrome related nephropathy, they give it this abbreviation APSN. This is referred to the kidney damage caused by vascular lesion in the glomeruli, arterioli, interior artery, interlobular arteries in a patient with the disease. And it can be primary or secondary. Clinical picture is hypertension, acute or chronic renal failure, proteinuria. This is the most important thing because it is easy to diagnose by just a simple depistaking the urine. Multiple cortical infarction, we call it mouth-eating appearance in the renal image. Differential diagnosis, it could be a Henoch-Schönlein purpura, thrombocytopenic purpura, malignant hypertension, renal crisis in scleroderma, preeclampsia, a side effect of cyclosporin, chemotherapy, and the renal transplant rejection. All these are differential diagnoses. Pathologically, it is characterized by fibrin thrombi in the glomeruli without inflammatory cell or vascular immune deposits. This is another one of APSN. Another one with electron microscope showing the emboli here. And this is another one. Here you can see the emboli in a very small vessels. And this is a serial of blood clots in the big vessel, small vessels, very small, and so on, in different stains. And the histology, we are not going to talk too much about it because it's not our area of expertise. And here, this is the anatomy again. Renal venous thrombosis, classically present with nephrotic range proteinuria. So if we got a protein more than the nephrotic range with a swollen bilateral feet, increasing eyelid buffness early in the morning. So in a selected cohort of patients, we need to think about it. And it needs a contrast CT and the MRI scan angio to diagnose that. It can be, the lupus nephritis can be associated with antiphospholipid antibodies, and it has another classification. And usually we find that the C3 and the C1 complement 3 and the complement 1Q more intense in the glomeruli. This is in the biopsy without glomerular membrane deposition. Their findings implies that complement activation induced by coordinated or coordinated with antiphospholipid may play a pathogenic role in the development of the renal tissue injury leading to thrombosis. However, not all the patients with lupus and the antiphospholipid develop glomerular membrane problem, microthrombosis. And the patient with primary antiphospholipid syndrome and the lupus share some common clinical serological manifestation. Primary antiphospholipid syndrome may evolve to full blown picture of SLE. This is something different. If you have a patient of antiphospholipid syndrome, every now and then it check whether they get lupus or not. You don't have to rely on the first diagnosis. At least once a year, look for is this patient has lupus or not, because lupus can be presented initially with antiphospholipid syndrome. Genetic factors is very important, and this is how is the catastrophic antiphospholipid syndrome with other manifestation can have a gray area together. Catastrophic. In catastrophic antiphospholipid syndrome, or CAPS, kidney is the most important organ to be affected. So it is very important in hemodialysis, and the nephrologist should be aware as soon as possible. And transplant, the antibodies are very important as well. For any patient who need a renal transplant, we need to investigate for antiphospholipid syndrome, whether primary or secondary. Here I'm going to talk about the treatment. The standard treatment, as all of you know, is that we start by aspirin. Aspirin alone sometimes has no benefit. we might not need aspirin at all in very mild cases. In very mild cases, me myself, sometimes I give patients some alternative aspirin every other day. And I got this from Professor Sir Yaqub, Magdi Yaqub. Magdi Yaqub, he was working in Hammersmith Hospital when I started to study medicine in the UK. When I came in 1996, I found some patients who has been under his care taking aspirin every 3 days. The bottom line of that the half-life of aspirin of the platelet is 3 days. So a warfarin with INRs is 2.6, high dose warfarin for recurrence, and from 3 to 4 associated with bleeding episodes, severe bleeding if we can go above 7 INR. Patient with antiphospholipid syndrome should be on lifelong anticoagulations. You don't have to rely on the patient's symptoms once you diagnose the patient, because if you got a blood clot, we might be sharing this event because we stopped the anticoagulant. A patient who developed thrombotic event despite being on anticoagulation should have their own warfarin dose increased or aspirin to be added. Corticosteroids itself or intravenous immunoglobulin has no proven ideal utility in patients with antiphospholipid syndrome. Nevertheless, the use of this drug may be used in a special situation or secondary. Prophylactic therapy for asymptomatic individual is not recommended. If you just diagnose a patient with no symptoms at all, you don't have to give a prophylactic treatment. But once you diagnose with the antiphospholipid syndrome, based on clinical sign, gives a start with aspirin, warfarin, and the heparin. All right, here we are. There is a difference in dose between heparin and venous and arterial. We don't need to go for that. We said that. Other anticoagulants. Yes, please listen to me carefully now. Aspirin is aspirin. Clopidogrel is not an alternate to aspirin. Please listen carefully to this one. Clopidogrel is a good medication in case of the patient is contraindicated to have aspirin. Not before that. Not really before that. Again, anti-factor X or this rivaroxaban or indoxaban or this kind of factor X inhibitor, factor 10 inhibitor, sorry, also is not an alternative to warfarin. And if you go to the warfarin mechanism of action in antiphospholipid syndrome and aspirin mechanism of action in antiphospholipid syndrome, you know exactly what I'm talking about. Because these two cheap drugs have a very good positive effect on the endothelial surface of the blood vessel itself. But if you have a contraindication, this will be a good alternative. Patient with CAPS, and the persistent positive endocardial syndrome, we can give hydroxychloroquine. Statin is very important, even if the lipids are not elevated. We can give rituximab or others. We can add cyclophosphamide, and this will give you the indication how bad the disease is. It is a life-threatening condition treated with intravenous immunoglobulin. This mechanism of action of the rituximab, it is a B cell depleting biological medicine, monoclonal antibody affecting the CD20. Nowadays, we have some other medication as well, some beta 2. There is a new medication, monoclonal antibody, Soralase. It is not available in the UK. Only available. It's not available to use in the UK because the price is almost. It will cost the trust about $500,000 of sterling pound, or $500,000 of Canadian dollars. And the paper said that it's very effective, but I think the patient, if he is not going to die from CAPS, he is going to die from poverty. So we'll keep this one till we have a insurance cover. And there is another medication, sirolimus, also can be used. This is mTOR inhibitors. And to be honest with you, I never used any of them. But I would like just to give you the update I know. Who should be checked for antiphospholipid syndrome? And this is the most important slide. If you have a patient with unexplained arterial or venous thrombosis, if you have thrombotic involvement in unusual sites, like ear, like eye, like empty cell syndrome, thrombotic involvement, thrombosis in a patient below the age of 50, recurrent thrombotic events, patient with lupus or and have hemolytic anemia, thrombocytopenia, women with recurrent pregnancy loss, we call it habitual abortion in the first trimester, or early preeclampsia in the before the 20 weeks of pregnancy. Patient with hypopituitarism, especially with the history of thrombosis, is present. In summary, antiphospholipid syndrome increasingly recognized as an important cause of renal injury due to thrombosis to any location within the renal vasculatures. And as I said a while ago, that after COVID, the number of patients we saw is much more than before COVID. It is well not known whether it is because of the viral infection itself, which is the most appropriate, or the vaccination. Vaccination can cause thrombocytopenia or any renal affection. And me, myself, I got my neutrophil count is below 1.3, which is considerably low. I got the advice from the hematologist and they told me, Omar, you are fine, don't worry about it, leave it, follow it up. And then now it is 2 point something, and I didn't do anything. So renal artery stenosis, renal infarction, antiphospholipid syndrome, nephritis, renal vein thrombosis, increased allograft vascular thrombosis. So for renal transplant, we need to consider all of that. Testing for antiphospholipid syndrome must therefore be considered in a patient with any of these manifestations. Nephrologists should be involved very early, and you don't have to say, I can't treat it, I know all the stuff. Please listen to my advice. Early refer to nephrologist. You will save your patient, you will save yourself, and you will be more than satisfied if you diagnose the patient early. Renal pathologists should be also aware about the disease. When you refer the patient to the pathologist, you need to write a careful, thorough referral, because you will look for different things. Anticoagulation remains the mainstay management of patients with renal involvement due to antiphospholipid syndrome, and the CAPS often require immunosuppressive therapy. The home message you need to take home today with you, look for suspected cases, consider blood pressure, urine dipstick. This is the most important one. If you pay your patient and hydroxychloroquine, you don't have to withdraw this one unless the patient got a side effect. And the one of the most common side effect, which is horrible, is the skin rash. Nephrologists should be involved as early as possible. So this is the home message. This is all about what I've said earlier. And this is the references. And this is me. Thank you so much.
Thank you so much, Dr. Omar, for this nice, elegant presentation. هذا موضوع شائك جدا. جزاكم الله خير.
وإياك حبيبي، ربنا يكرمك.
But we have two inquiries. Number one, some colleagues, especially non-rheumatologists, add glucocorticoids in any antiphospholipid syndrome patients, considering it as an autoimmune inflammatory. Is this a right way for management, and can you send them a message?
Would you please can you repeat the question? عارف الراجل بيقول لك عيد تاني؟ عيد تاني كده لو سمحت. One of your colleagues, yes.
Some colleagues, especially non-rheumatologists, consider it as an consider antiphospholipid syndrome as an autoimmune inflammatory disease. They add glucocorticoids as a routine. Especially
not as a routine at all. In special cases, if you got like a secondary antiphospholipid syndrome due to systemic lupus erythematosus, for example, and you need to treat the primary cause. If the primary cause requires steroids, yes, you can give. This is when the patient has antiphospholipid syndrome. But for pure antiphospholipid syndrome, I do not recommend corticosteroids. All what I do recommend is hydroxychloroquine if you need a medication. Have I answered the question?
That's nice. I need you to send a message for these respective colleagues. Yeah.
Tell him happy birthday.
Number two, some colleagues also substitute warfarin by direct oral anticoagulants.
Direct oral factor 10,
Yes.
the rifaxiban or apixaban, these kind of things.
Yes.
This is a clever thinking, but it is not. It's not the right choice. I do advise this colleague is to go back to the mechanism of. I can send it to you to give it to him, because this topic. I said it today. This is my master degree in Oxford, master degree thesis in Oxford, but not in renal. I put it in gynecology, gynecological lupus. And I went through all the mechanism of action of aspirin, warfarin, in antiphospholipid syndrome, and the factor X inhibitor or apixaban or rifaxiban, this oral anticoagulant, has no effect on the blood vessel itself. That's why it is not an alternative unless the patient has a contraindication to take the medication. If the patient has a contraindication to take the medication, in this case, little better than nothing. The oral I reviewed also some other studies from here and there from other specialists, because I keep updating myself all the time with the new things. And all the big shots in antiphospholipid syndrome say the same.
Yes, I do agree. I do agree totally. Welcome, Dr. Osama.
اهلا وسهلا. السلام عليكم دكتور عمر.
حبيبي اسامه الغالي.
يعني ناوي يوم مساعدي والله يعني.
And I think Dr. Osama need to add want to add a comment. I think.
اتفضل حبيب قلبي اتفضل. بس اللي قول لي الاول صبغت شعرك ابيض ليه؟
انا قلت دلوقتي اصبر لي الشعريه السوداء بس معلش.
اتفضل يا حبيبي اتفضل.
بالعكس انا مستمتع بمحاضره حضرتك.
العفو.
insist about the multidisciplinary approach. احيانا
زمايلنا في النفرولوجي يعني بيستأثروا الحقيقة، وأحيانا إحنا بنقول إحنا قادرين، لكن I think OB/GYN synchronize مع النفرولوجي مع الروماتولوجي. 3 of them they can serve the patient in a better way than anyone else يعني. And this case must be individualized, tailored decision to each patient separately in a very professional way. Thank you, Dr. عمر.
الله يحييك. انا عاوز اقول حاجه هنا برضو دكتور خالد بعد اذنك. احنا بنشتغل في autoimmune diseases inflammatory diseases affect the blood vessels, so it can affect anywhere. I got a patient with foot drop with Wagner's. I need to involve a neurologist. I got the ENT with Wagner's. I got chest interstitial lung fibrosis, scleroderma, lung involvement, systemic lupus neurological manifestation. So these subspecialties must be involved as early as we can. And the wisdom is ادي العيش لخبازه.
I strongly agree with you.
شكرا حبيبي، ربنا يكرمك.
Dr. Omar, thank you so much for your elegant presentation. We are proud for your presence.
الله يكرمك حبيبي. يلا نستمتع بالدكتور أسامة الغالي.
أكرمك الله يفضل. ربنا يكرمك دكتور عمر، ربنا يفتح علينا.
Welcome, Dr. Osama. Dr. Osama is the founder of the rheumatology department in Saudi German Hospital, Riyadh. We are proud of your presence, Dr. Osama. Dr. Osama Haji, the senior consultant rheumatologist in Muasaya Hospital, Dammam. is associate professor in Shams University. Dr. Osama غني عن التعريف.
أكرمك الله يفضل. I need feedback from all of you. بسم الله الرحمن الرحيم. I wish it is the last time to have a virtual meeting and we can see each other and hug and be close to friends, junior, senior colleague. We have to meet each other again, inshallah, forever. My presentation is very tough and it is difficult to be fair, but I will try to do all my best to be fair enough as much as I can. The title, as you can see, is Cardiovascular Risk and RA. The points here that we are talking about rheumatoid arthritis as always joint disease. Yes, it is an autoimmune inflammatory disease characterized by joint destruction and everything, blah, blah, blah. But juxta-articular manifestation or extra-articular manifestation is very important. If the patient of rheumatoid arthritis will die, he will never die from arthritis. He will die from cardiovascular disease. He will die from malignancy. He will die from infection. La qaddar Allah. I go back to this title and I keep this for 20 years to read it in an honest way. Accelerated atherosclerosis, an extra-articular feature of rheumatoid arthritis. This is published in April 2002. It means 20 years back. And I'm challenging our colleagues in cardiology that atherosclerosis in immune-mediated inflammatory disease, yes, it is not like rheumatoid, but think deeply about macrophage when you are treating. But the most important that we have to consider atherosclerosis and an extra-articular feature of RA. Again, this is an interesting one in 2019. This is a very challenging. The siblings of patients with RA are increased risk of acute Crohn syndrome. Second generation is not related to patient, it's not related to medication, it is not related to disease activity. So it is related to genetics, or it is related to inflammatory, or it is related to epigenetics. This is what we can explore in the next few minutes. And the conclusion from this clinical trial, the excess cardiovascular risk is present also among close relative or first degree relative to the patient with RA who shared susceptibility. It means the genetic susceptibility to atherosclerosis in addition to RA, or we are not controlling inflammatory in an optimal way. That's why there's epigenetics running to the second generation, and we have to take care about cardioprotective measures. All we have to take care about acute Crohn syndrome or cardiac complication because it is serious one. Before we have precision trial in celecoxib, and it is the first one to be, and 10% of this population they have rheumatoid arthritis, and celecoxib, naproxen, and ibuprofen increase the risk. But what our medication now? This is a clinical trial recently published, and they are saying in a very clear way, RA is associated with heightened risk of atherosclerotic cardiovascular disease, cardiovascular mortality, and subclinical atherosclerosis. And you can see here that any plaques in carotid artery, either non-calcified, calcified, or combined, they are increased in the dark blue in relation to the patient with RA. Again, interesting publication from Swedish population in more than 15,000 of the patient comparing RA with non-RA. In a very straight message, 40% reduction in the incidence of acute coronary syndrome over time in both RA and non-RA, but still RA is higher. And you can see along from 1997 up to 2014, still rheumatoid arthritis, the mortality and the subclinical affection is more. Whatever you are making follow-up for the patient is 1 year, 5 years, 5 to 10, or more than 10 years. The most critical one is the first year of presentation. That's why we have to be aggressive in medication. Somebody will say, yes, it is related to cardiovascular risk as in whole population, gender, age, smoking, diabetes, hypertension, dyslipidemia. But we have to look in a deep about the disease-related factor. It is common in this patient or not. That's why if we are going deep, we have to concentrate about the one on the right-hand side. Autoimmunity, especially NCCP, is very important. Systemic inflammation, cytokine, very critical, especially low-grade inflammation. Shared genetic, as we stated, with atherosclerosis. Specific circulating T cell can mediate both of them. And very critical periodontal disease. And please, away from my presentation, every rheumatoid arthritis patient must visit dental clinic to treat periodontal disease because periodontitis is a share between rheumatoid, periodontitis or periodontal disease and cardiovascular disease. And again, non-traditional risk factors, it is the same, especially stress and anxiety and depression. So if you are comparing men and women, you can see in a very clear way that the smoker, hypertension, disease activity, ACPA, total cholesterol, diabetes, triglyceride, disease activity. But interestingly, that if the patient is male and they have a low density lipoprotein, this patient is liable, not with high. That's why they are thinking that U-shape for low density lipoprotein to be common. Again, this is from 5,638 patients with RA with no cardiovascular disease. They are making this data from 13 rheumatology centers, and they are concluding 100 men, 148 and 241 women develop cardiovascular disease. The 10 years cumulative incidence is 20 and 11 respectively. But interestingly, men is more affected. We are lucky. Why you are lucky? Because our patient always female, our patient is younger, they are not old, and the common risk factor, but still, as a cardiovascular risk, men is more affected than women. ACPA is very important. If your patient has positive ACPA, or if your patient has increasing or titer of ACPA is increasing, this is very critical. Why? And you can see, I wish it is clear, if your patient has ACPA positive and they have DMARD, they have an increase of coronary heart disease, increase in a stroke, increase in cardiovascular disease, even fatal CVD, cardiovascular disease, or total mortality. So if your patient is ACPA positive, means your patient is liable to have more cardiovascular disease. What is the theory behind? The theory may be metabolic syndrome, but for me, the most important is vascular inflammation. They can precipitate heart failure, myocardial infarction, or the systemic inflammation combined with metabolic syndrome. So this is a very interesting one. This is a 91 patient with RA study. they are making the PET CT scan with FDG, and you can see there is ACPA seropositive is associated with higher level of vascular inflammation. That's why we have to take care about this assessment again with cooperation with cardiology. Interesting enough, in this again, vascular inflammation level using FDG, PET scan, CT scan in RA without non-cardiovascular disease. And you can see that rheumatoid arthritis is nearly the same level if the patient has coronary artery disease. That's why we have to take care about this risk factor in our patient in daily clinical practice. And we have to cooperate with our colleague in cardiology to give the patient the best service that we have. So what about if arterial inflammation detected? It can be detected in aorta, in cardiac, in a very clear way. But what is a risk factor? It is the most important is disease activity. That's 28 CRP, CCB again, and nodules. Lucky enough, we don't see nodules, but this is in addition to traditional risk factor, which is hypertension and obesity, BMI, increased BMI. So the uptake can be diffuse, can be focal, but the most important one is this. Although it is published in 2019, but it is the first one to test the effect of treatment on the cardiovascular risk or PET scan. It is a control, it is stable, it is a small group of patients, time 1, time 2 is a treatment, and the interesting that if the patient has TNF, small number of the patient, or non-TNF, which is triple therapy, there is decrease with time. Second message from this clinical trial, the first one to say, if your patient has an active disease, uptake will be increased. So treatment can affect in a positive way, and disease activity can affect the cardiovascular risk. So what about TNF? It is safe or not to be given to our patient in daily clinical practice. In this meta-analysis, they are collecting the MACE for most of the common clinical trial, and they have a clear message that TNF affect in a positive way cardiovascular event in patients with RA, either through inflammation or controlling the disease and indirectly control low-grade inflammation. But again, this is published in 2022, 3 months back in June of this year. This is an interesting because all the strong data come from Denmark, Finland, Norway, and Swedish. RA patient initiating biological therapy between the nearly 10 years, 2008 to 2017. They are making follow-up for the time for acute coronary syndrome was identified, and most of the patients are women. And during the 5 years follow-up, acute coronary syndrome happened in 780 patients. And you can see all of them is crossing the line with wide interval, confidence interval. Golimumab, infliximab, abatacept, rituximab, tocilizumab. But sure, they are overlapping, so there is no hazard for biological therapy. I myself, if I'm a patient as a cardiac, I will shift the patient to methotrexate and plaquenil. If I need, I will not use JAK, and this is in the second part of my presentation. So another challenge, it is disease activity or disease duration. It means if the patient has long-standing inflammation, this can give a result for the patient on the long-standing disease. And in that clinical trial, sorry to mention one by one, for the sake of the time, that disease duration, no difference. But if your patient has high disease activity, the red one, it can affect the cardiovascular disease events in RA. So it is disease activity. So controlling disease activity is very critical to cardiovascular. This is a publication from 2015 in a clear message that if your patient has remission in different modules, different assessment, they have a positive impact or lower risk of MACE compared to high disease activity. So controlling disease activity has a positive message for cardiovascular MACE. Again, this is recently published in last April 2022. This is Daniel Solomon. I'm interested in this guy. He's an editorial chief in arthritis and rheumatology. Time varying association of RA disease activity and two subsequents. This is clinical disease activity. If your patient has low disease activity, the hazard ratio will be less in comparison to mid or high disease activity. They are making more interesting data on another clinical trial in July, 2 months back, and they are saying MACE-free survival, and you can see the dotted line, broken line here is related that your patient is always in remission. So predicted MACE-free survival under clinic CDI is very important in daily clinical practice. That's why keep your patient. Another slide, very important one, you can see they are making two scenarios, along 5 years or along 6 months. And the best case scenario is to treat your patient early in the early 6 months to catch the most important critical part, which is the first 6 months to be in low disease activity or in remission. So what if your patient with RA or psoriasis or psoriatic arthritis develop side effect on biological therapy? Most of the patient continues the medication, part of them switch or discontinue. But you can see that the most important one in the middle part is comorbidity. Renal, hypertension, heart failure, diabetes, obesity, and chronic pulmonary disease is the most critical one. Again, may be related to disease, but comorbidity, it is restricting your choice. So if you are comparing in this population, the risk is there for conventional, a risk is there for non-TNF biological therapy in relation to biological therapy TNF, but sure, conventional synthetic demand is less. It is critical issue? Yes, it is a critical issue. Why critical issue? In this slide, the impact of RA on MACE in patients with and without chronic disease. And you can see here that myocardial infarction, all-cause mortality is the red one. It is common in RA and coronary artery disease. What is second to it? The second to it is RA, coronary artery disease. So if your patient is rheumatoid arthritis per se, the red one here, dotted one, it is a critical one, secondary to chronic artery disease. So again, cardiac death or MACE is very common in patients with RA, more dangerous if your patient has coronary artery disease and RA. So what about VTE? This is another presentation, but I will give only one message from this slide, that again, disease activity is very common and can be a risk factor for VTE in comparing a high, moderate, low disease activity and remission. This is for cardiovascular and DVT, VTE. No, it is the same for infection. If your patient is remission or low disease activity, you are controlling risk of infection in indirect way. If your patient controlling disease activity with low-grade inflammation, again, you are decreasing the incidence of malignancy, all type of malignancy. So what the message from this first part of presentation, that we have to control the comorbidity by non-pharmacological way. We have to be aggressive in treating rheumatoid arthritis. We have to cooperate with cardiology to assess cardiovascular risk. If we are achieving, we are protecting our patient from cardiovascular disease, improving the socioeconomic performance, decreasing the cancer, infection risk decrease, osteoporosis avoided, psychological impact improve. All this is by one target, which is remission or low disease activity. That's why I'm shifting now to the second part of the presentation. Sorry, Dr. Ahmad, this is not a lady. Sorry for this slide. This is a challenge with JAK inhibitor. What is this? If you saw this picture, you may saw the bird, you may see an old man, wise man, you may saw the lady, you may saw the boat. That's why we have a different opinion in evaluating the role of JAK in rheumatoid arthritis. We are here to cooperate with each other, synchronize with each other what we can do for our patient. This is the second title of my presentation, RA and JAK, double-edged sword, from rheumatoid and from JAK itself. So in JAK, we have a clinical trial. It takes about 20, by the way. It is now nearly, as far as I remember, more than 40 years since the discovery of JAK, and they have a long clinical trials for all JAK available. Even there is ongoing RA bridge and branch ongoing now about safety of JAK inhibitor. Yes, JAK, if not the same like of triple therapy, it is more, but the beauty of JAK is oral therapy. The beauty of JAK, it can be used as monotherapy. The beauty of JAK that you can interrupt it at any time if everything is going back to normal. If you are comparing, this is the JAK, this is methotrexate, the green one, and this is different dose from either tofa or bari or upadacitinib. If you are comparing with adalimumab, baricitinib, upadacitinib is significantly improved in comparison with adalimumab, not tofacitinib. What about the MACE event? MACE event, it is there. Everything is there. But again, this is indirect comparison between all of them. This is RA general population, adalimumab, upadacitinib, tofacitinib, baricitinib, and velgotinib 200, not available in Saudi Arabia. So MACE in all of them, but less in general population RA, but it is there for all of them. What about VTE? The same. It is all of them in general population due to disease activity, common finding in all JAK. So we have to look on surveillance. What does it mean? Post-market pharmacovigilance is important to see the safety of the data. If you remember, I'm old man, I'm considering myself old. If you remember methotrexate, when introduced in 96, they are saying it will cause interstitial lung disease, lung fibrosis. During biological therapy, it can cause TB. Yes, we are in need of pharmacovigilance to see the long-term safety, but we are using methotrexate now in a safe manner. In oral surveillance study, they are not achieve the target, which is non-inferior to TNF. For the sake of the time, this is the most important figure. If you are crossing 1.8 by any means, you are not achieving the target of non-inferiority. But both of them, there is no significant difference, either as a MACE or as adjudicated malignancy. So in oral surveillance, it's common. If you are comparing tofacitinib here, general population with tofa, you can see how many patients you have to treat to have one side effect. It is very important. It's very long. Number needed to harm is 412 to be treated for 1 year to have one single attack. I don't like for any patient, either me or my relative or the patient to have, but it is not a common message to have. Malignancy, it is the same number, but less, 275. That's why I will not use in active malignancy or malignancy in the past 5 years. I will never use JAK for this type of the patient. So it is common finding. In this, they are making sub-analysis or post-hoc analysis. It is published in RMD, Rheumatic Musculoskeletal Disorder, in Open 2020 in Jan. It is 73 per 10,000 patient year for TNF, for JAK, tofacitinib 91. So there is no major difference between both of them. So the most important message on oral surveillance, it is the first clinical trial to say, it is very important to say that in safety clinical trial or integrated safety, the high-risk population is not there, but oral surveillance is about more than 11%. They are receiving either TNF or tofacitinib or 5 milligram BID. So this is the baseline characteristic that great part of the patient are a smoker. They are older age group. The disease activity is very high. Simplified disease activity is 41. So it is a highest risk population. So what we can do for this patient, there's increase in the patient with current smoking, increase if the patient is 65 and more, increasing if the patient is hypertension or diabetes. That's why I will never use JAK in the patient who's 65 and smoker and the history of coronary artery disease. So what about new clinical trial? It is presented the last ACR and already published in Annals of Rheumatic Disease. They are comparing a very interesting one. They are making, this is data from this called STAR clinical trial. The baseline, they are collecting the data for this from different insurance companies in the state. And the most important, they are making duplicate of oral surveillance study, which is mainly from Medicare, which is an older age group, more than 65 years old. So if you can see in this, it is very critical. It is nearly the same, tofacitinib, TNF, either in all of them. But if you are mimicking what oral surveillance state, it is the critical one, Medicare. It means that there is a signal of cardiovascular in older age group, only more than 65. So if you are comparing integrated safety data between TNF and JAK, it is nearly the same, no difference. This is a data from, which is called before Corona. Now in the state, it's called Correvitas, that there is no difference. Even TNF is higher than JAK. If you are comparing this with oral surveillance, the signal is there, especially for 10 milligram. Lucky enough, we don't have, it's not approved. It is approved only in ulcerative colitis. But again, if you look into STAR, it is only difference if the patient has already older age group or coronary artery disease. So the signal is there, especially in high-risk population. Ladies and gentlemen, if you are treating rheumatoid arthritis, we have to consider all risk factor and comorbidity. Either cardiovascular disease, hepatic renal infection, osteoporosis, fibromyalgia, not to be aggressive in treating this type of the patient, respiratory disease, and gastrointestinal condition. The most important is cardiovascular disease. Why we do this? Because we have to make a balance between benefit of JAK, fast mode of action, specific oral elegant medication, but again, every medication has its own patient risk factor. We have to make a balance between both of this. We have to implement what EULAR recommendation for cardiovascular management in RA and other forms of inflammatory joint disease. This is another title, another presentation. But this is the last two slides for me, and I'm on time, lucky enough, that the patient demographic data is very important. You have to make a balance between the physician experience and the patient consideration and evidence to support the treatment balance between all these factors. So what is the take-home message from this slide? If your patient has coronary artery disease, if your patient has stroke, previous stroke, if your patient has peripheral arterial disease, if your patient has DVT or pulmonary embolism, I myself, and I'm inviting all of you not to use JAK at all. All JAK, yes, all JAK in a very clear way. And if we are in need, you have to make close observation, but we have to make a balance between risk and benefit. If your patient has risk factor without a history of atherosclerotic cardiovascular disease, we have to take care. But lucky enough, most of our patients theoretically is female, younger age group. The risk is only for female, male. If the patient is a smoker with coronary artery disease or cardiovascular disease, this is, and the smoker, this is most important. If your patient has no risk factor, no atherosclerotic cardiovascular, it's free to use whatever you like. By this, thank you for your time and concentration. I give more time for our discussion with our colleague, senior and junior and friend, and it is a time for synchronization, and most welcome.
Thank you so much, Dr. Osama, for your nice presentation as usual. ما شاء الله.
الدكتور عمر الأول الفيرنس.
لا حبيبي انت ما شاء الله عليك، ربنا يحفظك، حاجة جميلة جدا.
أكرمك الله.
استفدت جدا 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 من المحاضرتين، ما شاء الله عليك.
ربنا يكرمك.
ده مش غريب عليك حبيب قلبي.
أكرمك الله.
احنا في حاجة بنعملها يا دكتور أسامة بعد إذن دكتور خالد.
اتفضل.
في حاجة بنعملها، حاجة اسمها ريسك فاكتور اسسمنت، بنعملها على طول.
Yes.
يعني مثلا لو المريض بيجي لي كل 6 شهور، المريض اللي هو الريجولر ده بنعمل له اول حاجه طبعا البلاد بريشر والبروتين ان يورين وكده ومقارنتهم. تاني حاجه بنعمل حاجه اسمها، يعني وانا بعمل ديكتيشن للليتر بقول للسكرتيره تحط الكارديوفاسكولار ريسك اسسمنت بوليتس، والبوليتس دي بتبقى موجوده بنبعتها مع طبعا كل مكان بيختلف عن الاخر. Is that okay to continue in Arabic?
Let it in English because there are some non-Arab speakers.
Okay. I tell my secretary to put the cardiovascular risk bullets in the bottom of the list every 6 months or every year for the patient who has rheumatoid arthritis or any inflammatory condition because of a cardiovascular risk. And this will go to the GP to look at, because it goes without saying that, as you said clearly and nicely, that all inflammatory condition is associated with high-risk cardiovascular events. Some of our medications can increase that, like non-steroidal anti-inflammatories, steroids. Yeah, you mentioned all of them actually, but this is one of our routine. Yes. So raising the awareness is the bottom line. Like I like this traffic light, and I wish you all the green lights. Thank you very much for that.
But at least, Dr. Omar, we can do it every years. In all the age group, you can make it more frequent. But I always like the term that the only specialty that must work with team is rheumatology. You have to work with cardiology for any manifestation risk assessment, nephrology, gastroenterology, endocrine, orthopedic. That's why to work again in a team approach to give the best choice for the patient is very critical in our daily clinical practice.
Yes, you're absolutely right.
The question, what do you mean by interrupt treatment with the JAK inhibitors?
Yes, okay. نرجع للكوفيد ان شاء الله ربنا ما يجيبهاش. In COVID-19, if you remember that in B-cell depletion therapy, if the patient is receiving rituximab, and there is overlap between rituximab and vaccination. So the recommendation is to give the patient COVID-19 or SARS-CoV-2 vaccination after 5.5 months from the last dose of rituximab, or to vaccinate the patient first, and then you can give after 2 weeks the rituximab. This is why, because of long half-life. If the patient receiving TNF, if you stop now, still it's working. It will take about 1 month to 1.5 months, according to different biological therapy. But if you are coming to for me, it is a beauty, it's art. If your patient coming with any manifestation of infection, or even in Saudi Arabia, the patient is coming telling me that we are planning for conception, I like to interrupt all medication. Only for JAK, you can interrupt for 2 weeks or 1 cycle, and the patient can get free to be conceived at any time. That's why? Because JAK is a short half-life. It's only in hours. The longest duration is 14 hours. So if the patient has infection or any risk, immediately everything go back to normal if you interrupt the JAK inhibitor, whatever it is. Lucky enough, in Saudi Arabia, we have one of them by 2 and 4 milligram baricitinib, so you can go down to the lower dose or interrupt if you have. What I'm doing now, daily clinical practice, if the patient calling me, I have a COVID manifestation or any infection, I'm telling the patient immediately, you have to interrupt the JAK until resolution of all symptoms, and then you can go back. This is an easy to be manipulated or to be handled in comparison with methotrexate, in comparison with rituximab, or even for MMF. Rama, I'd like to add something.
Nice. I asked a question about what there is an alarming level for LDL.
قلت say again. اتفضل دكتور خالد مرة ثانية معلش.
There is what is the alarming LDL high reading to stop JAK inhibitors?
Okay. Say tocilizumab. Tocilizumab is acting through IL-6, right? And all JAK inhibitor. S2, JAK and IL-6, both of them, they are increasing the HDL and LDL. So you have to check after 3 months of starting either IL-6 or JAK, you have to check protein profile or lipid profile if when do you have to treat by statin, whatever it is, again with cooperation with cardiology. But the problem, there is a correlation, but it is beyond this presentation. There's some relation not clear enough between the lipids, LDL or oxidized LDL, and inflammation and the controlling inflammation, or even how rapid you will act this because you are affecting the influx and outflux of lipid. But for me, I like and believe hydroxychloroquine for me, it is the best medication that controlling second or even before methotrexate to control. I'm lucky enough in our hospital that we cooperating with cardiology, even while using plaquenil if the patient is high risk and have some signal of inflammation or pericarditis with ANA. They are cooperating how we can tailor the medication according what we have in our patient. We are not treating classification criteria or diagnostic criteria. We are treating our patient, but the best with what we have in our hands.
Thank you so much. جزاكم الله خير دكتور أسامة.
عمر انت علقت على الإشارة ما علقتش على العربية.
معلش المرة الجاية، بس بحب الفور باي فور بس.
أكرمك الله يا فندم.
شكرا جزيلا. شكرا دكتور خالد.
شكرا دكتور خالد. I do all my best to be on time and think we are on time. Thank you for your time and attention. تفضل تفضل.
Thank you so much. جزاكم الله خير دكتور أسامة وجزاكم الله خير دكتور عمر. We are very happy to be with you. إن شاء الله.
إن شاء الله بالتوفيق ودائما مجمع كل الناس وربنا يجعله في زين أعمالك. Great enough from South German Hospital and organizing committee, especially with Mr. Tamer. I know him for about 14 years. It's long enough.
Yeah, I was in Burj Al Arab, Alexandria last week for this HSR gathering. And I found that there is a new building with the Saudi German hospital as well there. So it is a good sign. 2 hospitals now in Egypt for Saudi Al-Almani. ربنا سبحانه وتعالى يطرح فيكم البركة جميعا.
نعم بإذن الله.
Okay, I'm leaving now if you don't mind.
خلاص we finished الحمد لله today. This is مسك الختام وإن شاء الله يعني nice ending. إن شاء الله we'll meet tomorrow finish the first day and we'll meet tomorrow إن شاء الله at 4 p.m. by Mecca time to start the second day إن شاء الله. جزاكم الله خيرا ونراكم على خير إن شاء الله.
السلام عليكم. السلام عليكم. شكرا جزيلا.
السلام عليكم.